Hope all is well. You're officially past halfway, I think, so that's good. It's always a plus. Yeah, so the agenda here is we're gonna split the review into two parts. We'll do all of the gross anatomy head to toe today, and we'll cover all of the bone synthesis, cartilage, the genetic stuff, all the later stuff in MSK, the physio. Yeah. We'll do that next weekend. We'll tentatively plan for Saturday. So we're basically splitting it in half. Do the gross anatomy today, and we'll do the more histology micro stuff next weekend. So I guess we're good to all right, we could go ahead and get started. I have a few housekeeping things I want to mention to you guys.
How are you doing with the gross anatomy? Are you finding it hard to memorize, or?
It's okay, it's coming along.
Okay, good. Unfortunately, there's no shortcut to this stuff. You know, we all try to, condense our studying, make it all good. But with the gross anatomy, you really just have to sit there and go over and over and over and over and over it. And yeah, it's so one-dimensional. And that's why Brady and I both endorse doing the Gray's questions as early as possible, because it allows you to see how it could be tested. Because, they do have the lectures that say imaging of, oh crap, what are they called? Like clinical imaging of the arm or whatever. And that is very high yield, but at the same time, the pathology questions are not going to be only that. You have to understand all of the muscles, the innervations and stuff, so that you know what can happen if something is lesioned.
Yeah, for sure. And another thing that I hope y'all appreciate, y'all have seen definitely the transition from FTM to MSK. Like FTM was very much all over the place. As soon as you learn how to study for that, you go into this, and it's a very different type of studying. But at least MSK has a more of a linear focus, right? You're just one system, or you know what I mean, that you focus on. So going forward, it'll be even more like that. It'll get even more clinical, and you're going to be basically worried about just the heart, just the kidneys and stuff. So I think it makes it a little bit easier to organize in your mind. Okay, so a few things. If you've been to these reviews, you know this already. If you go to the Scrubs Facebook page, bookmark the channel playlist. It's not technically the channel, it is a playlist. Because the channel is private or unpublished, you need to use the playlist link. But once you bookmark that, you'll have all of that, access to all of the videos that we do. What else? This is not affiliated with IEA, but if y'all do not follow IEA, this is the Instagram page. IEA is the Honor Society. If any of you are blessed enough to get above a 90, you will be able to join IEA next term. There's a lot of benefits that go into that, along with tutoring and stuff like that. So follow IEA. We're going to put updates on there. Also, if you are not aware of this, download the Inkling app. Y'all are going to be upset that we didn't tell y'all this sooner, but download the Inkling app.
They have time before their exam.
It's way easier to do these questions on the app than actually using the hard copy textbook. So you download the app, and you basically,
don't worry guys, I didn't know about this until like last term, so I didn't even get to use this in my term one when I was doing MSK. So
look, so you go, so there's an app too, and you can go to the website, you put in your book code, and you go to interactive assessment. I use my iPad, and so you could answer the questions or whatever. See, I don't even have to read the question. There you go, that's right. You can just do it that way, and then it tells you the answer right here underneath it. So you don't have to like thumb through the book. It's way easier, way faster.
I'm gonna add something to that. Sorry to cut you off.
Yeah.
But if you guys are going to use the website or the app, just make sure that the first few questions are going to be those first, second order questions. Those questions do not start from the assigned questions. So for example, the questions that they gave us, like on our practice questions or our sheet, they start from 1. But make sure when you're doing it on the website, I think the first few questions do not start from there. So you have to add those questions. You got to start from like 5 or 6 because the first time I did that from 1. And after I was done, I realized, crap, I missed a whole ton of questions.
So are all the numbers off? Like the ones they assign are not the same?
Yeah, they're slightly out of sequence.
They're off. Yeah.
They're off. Okay. I did all of them. I mean, like you
I
can.
did not.
Okay. Well, some of them are out of the scope of what you're doing, but I didn't feel like thumbing through it, so I didn't realize that. But yeah, that's a good point. Lindsay, do you have that file posted that you made when you took all the
So-
questions out?
I didn't do MSK because
Okay.
there were just so many questions, but for every other module in term 1 and term 2, I actually took screenshots of all the assigned questions and put them in my own document because it made me mad that I had to flip through everything. And so CPR 1, 2, ER, DM, NB, all of those, I have documents on my Google Drive that are just the assigned questions from Grays. So the explanations aren't in there, but it makes it easy if you're like me. I like to print it off because I like having a hard copy. Oh my God, I can't talk. Or if you have a tablet and you want to use the tablet and go and flip through all the explanations in the back of the physical Grays book. But I have that for everything except MSK because MSK was a lot of questions.
Okay, so sorry, I didn't realize the numbering was off. That may make it a little more difficult, but I mean, I thought the app was a lot faster. Okay, anyway, I'm on Scrubs. The slides are up there. Lindsay's Dog Mom. Go look at our extra resources, the additional resources. We put a bunch of extra stuff, tables, whatever we found useful. So just scroll through that and see if there's anything you think's useful there that you would like to use. But
I'm gonna insert right here. I've had a few people reach out to me your term, last term, about really nice, pretty charts that they have found and been given that lists all of the muscles and everything about the muscles. Be careful because those charts, while beautiful and pretty and organized, they have a lot of information that is not high yield. For example, origin and insertion is not high yield. You will not get an origin or insertion question on an SGU exam. You will not. Blood supply, you will talk about anastomoses, and Brady is going to talk about this today, but do not memorize every single artery that goes to every single muscle. If it's an anastomosis, memorize everything about that anastomosis and move on. The two big things are going to be innervation and action, and then cutaneous innervation, but that doesn't have anything to do with the muscles. Those are the two big things. If you find a nice, beautiful chart, anything else on that chart other than innervation and action, you can look over it, but don't spend your time on that. So just want to put it out there.
I did not know it going into the exam. I promise you, the insertion origin stuff. It's just root memorization when you're doing it like that. We've said it a million times, keep it clinical. Everything in here is clinical. You should be getting to the point when you're studying, if you're questioning whether it's high yield or not, you should ask yourself, how would they write a question about this, right? It has to be clinically relevant. And the further you go along, the more that'll hold steady. So you'll see the stuff we're pointing out, the stuff we did, are doing, it's all clinically relevant. Okay, so if y'all did attend Kishore's review last time, we shared some of these slides, but we're going to go back through them again, just because the upper limb is so highly tested and it is a difficult thing to learn. So we'll do that kind of quickly and then go along. Should be doing your grades. If you notice this name right here, he's the dean of the school. So that's probably important that you use the book that the dean of the school wrote. Okay, now cadaver lab. Kishore could talk about this. So we left the island during MSK, our first term, a billion years ago. So we didn't have this cadaver lab. Do you have any advice going into that, Kishore? I mean, they shouldn't worry about it now, but.
Yeah, so there is a a clean document that was compiled by a couple of upper termers from the past, and that document was more helpful than just the rote memorization and the stress of just getting through MSK. So for now, I would say just really hone in on the stuff that Brady and Lindsay are kind of giving to you guys, as well as the clinical correlates that they're emphasizing. And then when the lab kind of time comes around, make sure you guys review that document, because that document, essentially what you should be able to do is go through, start filling in the details of like innervation, where like if it has an embryological origin correlate, use that. They don't do first order questions for the lab exam. It's just like any other XGU exam. It's going to be emphasized on like second order or even third order questions. So just be aware of that, because a lot of us kind of went in with our open eyes and we were just like, hey, we just have to identify the muscle. It wasn't the case. We needed to know the innervation and stuff. So if you guys need a little review session or something, we'll cross that bridge when we get there.
But for now, there won't be any cadaver images on the exam. So this is just for now. Just don't stress too much about this. You do it when we get there. All right, back in spinal cord, we'll start there. Super high yield point. Why don't y'all direct message us with your answers, and we'll go from there. All right, good. So if we yeah, so the point here is that this cona medullaris, right? The cone point, the bottom of the spinal cord ends about L1, L2. Below that is the cauda equina, which literally means horse's tail. And the point is, when you do the lumbar puncture, if you imagine sticking a needle through, like just through your hair, right? The hair's going to separate. It's the same thing with the cauda equina. They're technically nerves, but they're split nerves. So when you stick the needle in there, you can get CSF out, but you're not going to injure the spinal cord. If you do it around L1 or above, you can possibly injure the patient. So point being, you want to go L4, L5. If for some reason you can't tap it there, they can go up to L3, L4, but you want to be safe there. So this is for an adult. All right, and you can see that here. This is that conus medullaris, and then the cauda equina, the horse's tail down here. All right, try this one. All right, so here's an interesting thing that sometimes happens. Sometimes they'll give you a disease, and you'll cover this later. I'm not sure that y'all even really talked about it. And don't freak out, because in the next sentence, they tell you what you need to know about the disease, okay? So you don't necessarily need to know it. You just need to know that there's just chronic vasospasms that's happening in the cold. So if you can imagine in cold weather, if you're having vasospasms or decreased blood flow, particularly to the extremities, you're gonna get this ischemia. You're gonna get people complain of like purple or blue nails, their lips turn purple. So this is this Raynaud's phenomenon, or Raynaud's disease. But what they're talking about here is sympathetic fibers. Remember, you're going to go through this again and again. The sympathetic system is about fight or flight. It's about vasoconstriction primarily. In cold weather, you're going to be vasoconstricting to keep that blood flow centralized. Okay, so that's what's going on here. It's like a heightened response. Okay, so this Raynaud's disease is a heightened sympathetic stimulation, particularly to cold weather. So you're thinking about these sympathetic vasoconstricting fibers. Good job. All right, and then again, same principle. when we talk about sympathetics versus parasympathetics. Just remember, if you're ever confused, just remember sympathetics is running from a bear. What do you want to happen in that case? Versus parasympathetics is rest and digest. All right, try this one. All right. So, and I know, like, for the exam, y'all have more time with this, but we have a lot to cover, and we don't want to keep y'all. Everybody pretty much dies at the 2-hour mark. So sometimes we go over, but we'll take a break. But we're going to try to keep this short and sweet. So let's see. Some weakness in functioning muscles. So what they're basically asking you here. So let me just preface this. So FTM was very much buzz heavy. MSK is a little more clinical, but there are a lot of buzzwords too, a lot of pure definitions. When you get to CPR and onward, it's a lot more clinically physiology based. You kind of have to think through things. But here they're basically just asking you how the dorsal primary rami works. So it's one of those things, if you didn't come across it, it's hard to know. But the dorsal primary rami, it's basically going to innervate those innermost or the intrinsic muscles of the back, okay? The ventral primary rami is going to do all of the muscles of the anterior chest and all of the superficial muscles of the back, so the bigger muscles. So I was going to do like an axial. So if you say this is dorsal and this is ventral and this is the spinal column, the dorsal is just basically going to cover this area at the intrinsic back, where the ventral, so if we were looking at, let's say, an MRI, the ventral is going to kind of do something like this, right? All of the anterior muscles plus those big muscles in the back. Now, I put this on here for a very specific reason. So let's say this is kind of like the art of taking these sorts of tests, right? So let's say you didn't know how the dorsal primary rami, you were like, I really don't know, right? But look at this. Let's see how can we use the test to our advantage? Well, this is let's see. This is a big muscle. This is a big muscle. This is a big muscle. This is a big muscle, right? So if we categorize this, you may be able to come across with, well, this one really stands out because it's one of those intrinsic muscles of the back. So a lot of times it doesn't work out this way, but sometimes you can kind of work things out like these all fit together in one category, or maybe A and B are very similar, so neither one could be used. But this is kind of one of those tricks you can use to try to work out answers. All right. So yeah, it's the intrinsic muscle, dorsal primary rami, do the intrinsic muscles of the back. All right, so don't be worried about the brachial plexus. Technically, you don't really need to be able to draw it out. I mean, maybe it's a cool party trick, or probably not, actually. It's not a cool party trick unless it's a bunch of med students. But you really need to focus on the terminal branches and stuff. So we'll get there in a second. But you can see here, this dorsal primary rami is going to do these intrinsic muscles, and then the larger muscles of the back and the ventral muscles, the anterior muscles, are going to be done by the ventral primary rami. So these are some of those intrinsic muscles. The ones that you don't hear a lot about, those are the ones that are intrinsic. Most of the time when we talk about injuries, we talk about injuries to those larger muscles. And these are some of those superficial or larger muscles here. And these should be familiar to you guys. But again, when you're studying this, when you look at the innervation, you want to look at what are the deficits if there's an injury there, what's supposed to happen, what's not, or what's supposed to happen, or if an injury, what would happen after an injury, right? So these are those larger muscles. All right, this is straight out of your notes. So what's this? Somebody could tell me what it is first.
I think it's like sacrococcygeal. Mm-hmm.
Yep, sacrococcygeal teratoma, right? When you think of teratomas, they're classified as of embryonic origin, right? So what's classic about this sacrococcygeal teratoma is that it has all three germ layers. So you want to remember that. So there's kind of buzzwords that that help to differentiate different diseases. But yeah, so it has all three germ layers, meaning it's of embryonic origin, right? Because eventually the germ layers split until they're they get to their more permanent cell type. So another characteristic of that is it's a remnant of the primitive streak. Now, again, when you talk about embryology, we're going to stress to you the best way to do that is to look at the clinical derivatives of it, right? So you don't need to necessarily know that the tadpole turns into a tadpole with arms, which turns into a human or whatever. You want to know that what are the deficiencies? If there's a deficiency, where did it happen and what was the problem? So the primitive streak is very early on in the embryological process, right? So that's why all three germ layers are still there. And you could see that derivatives from all three germ layers. So a lot of times teratomas can form in the uterus as well. They'll take those out and you could see sometimes they have teeth and hair and stuff. So it's from germ layers. So just knowing about this, sacrococcygeal teratoma, primitive streak, all three germ layers, that's what it looks like. It'll be good to go. All right. Yeah, go ahead and answer this one now.
I have a quick question.
Yeah.
Would they would the exam like ever test on like the very small, I mean, I feel like they would, but the small details of like how the primary umbilical vesicle, like all that stuff forms?
So like classically, it's always been in relation to deficiencies or disorders and stuff. When they talk about just the actual process of normal development, they really don't dive into that. It's usually like, this kid's got webbed fingers. What was the process that was supposed to happen that prevented that? You know, and it was like, well, they didn't undergo apoptosis. That's usually the approach they go for. Just because clinically, like knowing the normal process isn't, I mean, it's not super high yield clinically, but when you see some sort of disorder, it's really good to be able to say, well, this was the problem. Is there any associated problems that I should expect with this?
Thank you.
Yep. But I think Lindsay had mentioned this previously, but a good trick of doing embryology is start with the end of the lecture, because that's where they do the clinical stuff. And then kind of, you know, it's a good approach to studying in general. Say, this is the disorder, and then you kind of break it up into what are the problems, what's normally supposed to happen, stuff like that. But especially for embryology, because, you know, 2/3 of the lecture is just normal development. It's just not highly tested. All right, so you need to know all of these. We'll go through them. So point being, spinal cord and meninges, that sounds bad, right? You don't want that bulging out of your lower back. So in general, the longer the word, the worse it is, right? So myelo correlates to the cord, meningios, the meninges, seal is the actual outpouching of it. Spina bifida occulta usually is asymptomatic. They diagnose these kids, there's like a little tuft of hair, they say, on the back. And meningoceal will obviously be the same as myelomeningeal, except you won't have the spinal cord in there. You'll just have meninges, okay? So you definitely need to know these. What's the other one that doesn't have anything? Anybody? It's like completely open. Didn't you cover that?
Rachycysis?
Schisis, myeloschisis, that's it. Yeah, the schisis one. That's really bad, right? Because you don't have a covering. Seal means there's a covering, but myeloschisis is the one. But they do like to test on these differences here, because it's fairly common. And what is the deficiency in the mother that tends to lead to this?
Folate.
Folic acid, very good, or folate, same thing. Yeah, there it is. Good. Right, and you can see that here. This is that little tuft of hair. You see that the vertebral arches here didn't form to make the complete vertebral body, but there's a little tuft of hair. Meningioceles there. Meningiomyelocele or myelomeningeocele, same thing. You can see that the spinal cord is there, and then here it is, myeloschisis. Yeah, so it's a complete opening. So that's very bad, obviously, a conduit for infection. Now, The sooner you learn the neural crest cells and the derivatives, the better. They're kind of a little all over the place, but they tend to be neurologic of origin. We have this running joke that if they ever put neural crest cells in the answer choices, it's always the answer. That's not necessarily true, but it is. So just, it's like one of those things they like to test on it, and it'll come up again and again. Some of the GI disorders and stuff like that correlate to failure of migration of these neural crest cells. So keep these in mind. Neural tube derivatives tend to be CNS. There are some PNS ones, and then these neural crest derivatives are a little all over the place. There's more than this, but this is all you need to know for right now. If you want the full list, you can go look at first aid. All right, try this one. All right, so what are we talking about? Now we have an anterior dislocation, right? So if we just had a fracture, we would be talking about spondylolysis. But because there's anterior dislocation, it's spondylolisthesis. I think is how you properly pronounce it, spondylolisthesis. So you can say, and I don't think they'll do this for you on the test, technically you can have an anterior displacement without a fracture, but especially in the lumbar area, like you're not going to see this anterior displacement without a fracture, right? Sometimes they'll have this spondylolisthesis in the cervical area that doesn't have a fracture, but like that's like more advanced than we need to worry about. So this anterior displacement is going to be what you're looking at. So simply put, don't like confuse this. If they have a fracture on the test with no anterior displacement, put spondylolysis. If they talk about anterior displacement, regardless if there's a fracture or not, put spondylolisthesis. I know sometimes they put like both of them together and stuff. They make it more confusing than it needs to be. But if there is anterior displacement, put spondylolisthesis. That's it. All right, so they talk about this oblique view where you see this Scotty dog appearance, right? Here's the head, here's the neck or the collar. This fracture, does anybody know what this is called? What is the weak point? It's not on the page, I don't think so.
Pars inter, I think.
Pars what?
Interarticularis.
There it
Yeah.
is. Very good. Yeah. Pars interarticularis, right? That is the weak point when you get these fractures, compression fractures, or some sort of trauma to this area. You fracture the pars interarticularis. Very important point because that's going to be the spondylolysis, and that will be that anterior displacement. Now, keep in mind the anterior displacement is of the superior vertebrae. Okay, so this is what you'll expect. If you were doing this on the test or if you were a radiologist, you could kind of do like this and say, well, it's supposed to go down like this. It doesn't, it makes this right angle. So obviously there's a problem, okay? And see, so I doubt they would give y'all anything like this, but obviously if you trace these down, it doesn't look like there's any sort of anterior displacement here. This is obviously the front of the patient, and you can see these spines in the back. That's the back of the patient. Here's the hip. So we're looking at the lumbar area, but you don't see any displacement. Everything lines up. So this is just spondylolysis. And then here, if you were to trace it down, this is the front of the patient over here. You see the spines in the back. L4, you see the slip disc, well, not slip disc. I don't want to say that, that's a different thing, but you see this anterior displacement of the vertebrae. I don't know if, did y'all cover MRIs yet with like M1 or T1 and T2 weighted? Y'all did? Okay, good.
Yes.
Does somebody want to tell me what this is? Does it say it somewhere? Because there's a trick to doing these. Yeah, it's T2. So the problem is that, okay, so T1 is fat and T2 is fluid, right? So there's a problem because in fat, there's a lot of fluid, so it tends to light up anyway. So the trick into looking at these is you need to find an area of fluid where there's no fat. Perfect area is the spinal cord, or the spinal column, where you have CSF. So if the CSF lights up, then you know it's T2, right? Whereas this, you say, well, look at the fat lighting up. Well, that's because there's a lot of fluid in the fat. So the idea here is you want to find an area of fluid that doesn't have fat. So I always look at that. And you could see the cauda equina kind of diving down in here, right? And then the conus medullaris is right about here. So
Brady, I was wondering if I could just quickly ask, so in spondylolisthesis, does that mean that the neck always gets fractured of the dog?
Yeah, from my understanding, I mean, there could be rare cases, but from my understanding, and all you need to know is that, yeah, there's a fracture of this pars interarticularis that causes that anterior slip. Technically, you could get a slipping like this without the fracture. It tends to be cervical, but in the cases where y'all, when y'all talk about it, it'll be straightforward. If they say anterior displacement, it's going to be listhesis.
Okay, thank you.
All right, let's try this one. That's right, Kishore. I agree again. I called Kishore in the middle of the night and asked him fourth order questions just because. Getting them ready for those rotations. All right, cool. So DINs, right? Remember the DINs? So there's the atlas, which is C1, right? Atlas meaning like a circle. And there's the axis, right? C2, which is where the DINs is. And it's gonna, this atlas is gonna revolve around the axis, right? So the DINs is that little protrusion that protrudes superiorly that kind of helps the head to move, you know, along that axis, for lack of a better term. So what are we talking about? Well, this is that transverse ligament of the atlas. That's what the ligament that actually holds the axis against, or the DINs against the atlas, right? The DINs of the axis against the atlas. So if this ruptures in some sort of injury, tends to be a MVA, a motor vehicle accident, you can get a lot of problems here. Now, if you look here, what I want to point out is that this is the worst one, this type 2. So if you want to know one, you want to know type 2. I'm sorry, if you want to know one of these, you want to know it's the type 2 one. That's the bad one. The reason being is that that transverse ligament crosses right where that fracture is. And if it presses down at that point, you can get avascular necrosis because there's some smaller vessels that supply blood to the DINs. So if you fracture it there, a lot of times you get decreased blood flow or avascular necrosis to the tip, just the tip though. And then, but that the vessels are pretty much protected in these situations. It's just that it runs right there. All right, let's try this one. Super, yeah, this is a really important thing, but we'll break this down for you guys. Right, so y'all have been doing your Gray's questions. Good, so basically we're just asking what nerve is compromised at this point if you have some sort of herniation at L4, L5. Well, we know if we're in the lumbar regions, it's the lower of the two. So let's break this down. Now, so we'll start with the cervical region. So let's just take C1, 2, 3, 4, and C5. So now the C5 nerve is going to be what exits here. So C1 is going to be above, the nerve is going to be, let me annotate this. So C1, C2, C3, C4, and C5, right? So the nerve actually starts above the vertebrae in this region, right? So if you have some sort of herniated disc, like right here, it's going to come and it's going to injure C5, okay? Cool. So in the cervical region, it's the lower nerve that's going to be injured. Now, if we look here, what ends up happening is you have a C7 nerve. I'm sorry, C8. Yeah, C8 nerve, which is extra because you only have 7 cervical vertebrae. But you have 8 nerves. What that does is it bumps all the nerves down one. So now T1 nerve is below the T1 vertebrae. So because there's an extra, a C8 nerve, and there's only 7 cervical vertebrae, that 8th nerve is going to push everything down one. So now the nerve is going to exit below the vertebrae. Okay, so whoops. What you see here is that the nerve above, the T7 nerve, is going to come out before. Okay, so in the cervical region, it's the lower of the two. In the thoracic region, you can see because we bumped it down, it'll be the nerve that's above. But the one they like to talk about most is the lumbar region because that has the most force against it, right? The most pressure. It's the lower of the nerve of the vertebrae. So you can see here. So herniations tend to happen here because there's a lot of pressure there. So what ends up happening is the nerve will still exit below, okay? But it exits above the disc, right? So T4 is still gonna exit below the nerve for L4 is still gonna exit below the disc, but it's safe because the L4 nerve is gonna exit below the L4 vertebrae, but it's going to be safe because it exits above the disc. In the previous cases, the disc is above the nerve in that little space, so that nerve will hit it. But in this situation, the nerve is superior to the actual disc. So even though L4 comes out, it's safe because the disc is below it. So what you actually see is that this L5, which actually comes between L5 and S1, L5, yeah, right. So this is going to be the one that's compromised, okay, because the nerve exits before. Okay, so on the test, you don't want to have to think about any of that. So just remember this, that if it's cervical, C2 and C3, the one that's injured is going to be the lower one. If it is thoracic, T4 and T5, it's going to be the upper one. And if it's L4 and L5, they'll probably ask you where the injury is. It's the lower one. So lower, upper, lower. But it's just tricky because in that lumbar region, the nerve's going to exit above the disc. So it's not going to be injured. Okay, hope that made sense. All right, and you can see that here. So right, so look, this is the L4 vertebrae, this is L5 vertebrae. So L4 technically still goes below it, but look at the disc. The disc is below where the nerve exits. So this nerve is not going to be pinched or compromised. You're going to get the one that goes below it, the L5 nerve that's compromised. All right, upper limb. Let's do this one. All right, so what you need to remember here is that the clavicle is usually what separates, okay? So if you get a separation of the clavicle, you have two tendons that help to, or ligaments that bone to bone, so it's a ligament, ligaments that attach there. So let's take a look at this. You could see the coracoclavicular, right? The clavicle, and you can see here where it attaches. So that's going to separate. And then you have the acromioclavicular as well, and that can separate as well. But anything with clavicle in it is going to be what separates. The ones that attach the acromion to the chromium to the coracoid. What is this called? The coracoid process. Is that right? Coracoid process to the acromion. Those are stable. Okay. The ones that attach to the clavicle are the ones that tend to separate. So you can see very clearly here that the clavicle is supposed to attach to the acromion. This is very much separated. But when you get that injury, secondarily, you also get this coracoclavicular injury as well. The reason that the clavicle is pulled upward or superiorly, I will get to this a little later, is because it attaches to that sternocleidomastoid, that muscle that attaches to your neck. So when you get separation here, that muscle in your neck tends to pull it upwards. Okay, so don't get bogged down with this. There is a video if you do want to learn how to draw it out. It's like go on YouTube and search like draw the brachial plexus in 30 seconds, and they show you a trick to do it. But the most important thing you want to remember is the terminal branches. What are the clinical correlations to if there's an injury to these terminal branches? The mnemonic to remember this from roots to branches is real Texans drink cold beer, roots, trunks, division, cords, and branches. But again, like I said, the terminal branches are going to be what's mostly tested on. When y'all get to the cadaver exam, you're going to want to be able to kind of identify. You want to be able to find this M. This M is very important, but we'll get there. When you get there, we'll talk about it. But it has to do with the terminal branches and how you identify it on a cadaver. But for now, you want to worry about the clinical stuff. So let's do this one. Did Lindsay leave me? Where'd she go? Oh.
I think she had some connectivity issues, so she said she'll join us in a bit. I'll keep you company, Brady. Okay.
She's got some, I'm tired of hearing Brady talk issues. That's what it is. And she wanted a break. Yeah.
I heard that, Brady.
Damn it.
I'm changing locations because I was dogs.
No worries. All right. So, well, does it say in here, what does this child have? What is this called? Yeah, Erb's palsy or Herb Duchenne palsy. What is this position called? This is a great way to know this. Does anybody know what they call this? The waiter's tip, right? So if you think about like a waiter leaving the table and he's like, yo, throw me a couple extra bucks, like he puts his hand out like this. But this helps me to remember what's going wrong, right? So I like, as you know, a good way of learning things is to chunk the information. So this is going to be an injury to the upper brachial plexus, upper trunk. When we talk about Klumpke's palsy, that's going to be a lower trunk injury. Okay, so you want to kind of keep those together. I have slides coming up, but what the classic way that they'll present this is a difficult vaginal delivery. And when you have a difficult vaginal delivery, sometimes a child's head is hyperlateralized or hyperflex, whatever. It gets and you tear the upper brachial plexus, right? You can imagine if you stretch this way, this upper brachial plexus is stretched. Okay, so when you do that, you tend to get injury to the, oh, sorry. We'll do this one first and then we'll talk about the muscles. So think about the waiter's tip position here, and then we'll kind of go through it. So the arm is adducted, ADD, right? So here's the trick. So adducted versus abducted. like ADD, the D's are closer together, so the arms closer together, where abducted, they're further apart. So it's up. I don't know if that helps, but yeah, so adducted or abducted. So the child's arm is adducted, it is medially rotated, and the wrist is flexed, right? And that's that waiter's tip position. So you have to be careful in the exam, because they could either ask you in the question, I could write the same question and say, what is the deficit, right? Or is that what they said? Okay. Okay, so they're asking you what the deficit is here. They could very easily switch it and say, how should it be, right? And so the arm, so they could say there's an inability to laterally rotate the arm, or the answer could be like the arm is medially rotated. So they could either ask you, how does the child present in this clinical scenario, or what is the deficit, right? So they're completely opposite. Even, the child cannot laterally rotate the arm is the same thing as saying the arm is medially rotated. So watch how they ask the question. I know sometimes in stressful situations, those are the little things, because they will put them both as answer choices, right? So you just don't want to get little things like that confused. But yeah, so these are the muscles that we talk about with this waiter's tip position. The suprascapular nerve, right? That's going to help you to abduct, right? Abduct the arm. Axillary nerve as well, right? Musculocutaneous nerve. So that's why the arm is medially rotated, adducted, and the wrist is mildly flexed. So these are the primary muscles that are affected. Now, when you talk about Klumpke's palsy, very similar in how the deficit or the trauma occurs, except it's the lower brachial plexus. So the clinical situation they give you here, let me see if I have a question. The clinical situation they give you for Klumpke's palsy is somebody was in a tree and they fell out of the tree and they tried to grab onto the tree, and it stretched. So whereas in Herb Duchenne's palsy, you injured the upper brachial plexus, this time you stretched the lower brachial plexus and tore it. So the clinical scenario here, if you tear the lower brachial plexus, is you get what's called Klumpke's paw. So you're tearing the roots of the nerves for like the ulnar nerve, the median nerve, and you see these downstream effects. Okay, and that's going to get the Klumpke's paw. But it's very similar. It's just Herb Duchenne's upper, Klumpke's palsy is lower. You can see that here. These are the three that are primarily injured that we talked about, right? So you can't initiate abduction, axillary, you can't continue it up to 90, and then forearm flexion and weakened forearm supination has to do with the musculocutaneous. They do like asking these angles, right? What is the one? Okay, so we have two. So suprascapular is 0 to 15, axillary is to 90 degrees. What's the one that goes over your head, or two that go over your head?
Serratus anterior and trapezius.
Yeah, right, good. So they will ask you that. So watch the angles on that. Very good. All right, and you can see that here. Look, he's in a waiter's tip position. So you stretch this ipsilateral upper brachial plexus, and now the arm is compromised. Okay, this is great. If y'all haven't seen this, this is wonderful. This helps you to determine, when you're looking at the brachial plexus, what are the downstream problems. So label your fingers, C5 through T1, right? That's all of the roots of the roots. Well, yeah, roots of the brachial plexus. So if you do 3 musketeers, that's the first 3. That's musculocutaneous, right? So if you have a C5, C6, or C7 injury, you're going to affect the musculocutaneous, because when you look at the brachial plexus and all the roads kind of come together, this is how it breaks down very simply. C5 through C7 is musculocutaneous. Assassinated, C5 and C6 has to do with axillary. Radial is rats. That's all of them, right? So when it all comes together, you can see that. Mice as well is median nerve, and ulnar C8 and T1. So let's look at this practically, right? So if we have a Herb Duchenne palsy, we're affecting the upper brachial plexus, C5, C6, maybe also C7. So we see musculocutaneous is compromised, axillary is compromised. We actually do have some injuries here, but they don't talk about them as intensely as the musculocutaneous as well, and the axillary, and then what was the third one we talked about? Suprascapular, right? So that comes off of the first branch. I'm sorry, the first root. So that's what's injured, but you could see they have also minor injuries here. Now, what if we looked at Klumpke's palsy? We're primarily affecting the lower brachial plexus. So look what we have affected. Are we going to affect musculocutaneous and axillary? Not likely. That's coming off the upper brachial plexus. But as for the radial, the median, and the ulnar, those are affected. And what are the complications if you affect these? C8, T1, what are they? They're downstream effects. You're going to see it in the hand, and that's how you get Klumpke's palsy. Okay, so easy points on the test. Just keep these separated. Print this out if you must. Draw on yourself. No judgment here. All right. Again, Klumpke's palsy. What is the clinical scenario they'll talk about? Some dude's hanging in a tree. He falls out. He tries to grab on, tears the lower brachial plexus with his arm elevated. All right. Now, again, knowing these is good in regards like straightforward. The Grace questions will help. Some of the ones they love serratus anterior long thoracic, that wing scapula that you get if you press against the wall. You know how they love it because there's like 20 questions in Grays asking the same thing. There you go. So the more questions in Grays they have, the more the dean of the school likes it because he wrote the book. All right, use it to your advantage. So that's one. These aren't super important if you want to know them. Again, not super important clinically, right? How are you, they do like the thoracodorsal and latissimus dorsi because it's such a big muscle in your back, but some of these are very small. It's great if you could draw them out, but not super high yield. Again, what we were saying, this is that M formation that we see. So when you look at a cadaver, I'll just tell y'all now, the idea is to find where the musculocutaneous dives into the muscle. If you see the point where it dives into the muscle, you could trace the M back, and then you could see that, then you could find the radial that goes underneath it, okay? Not too high yield right now, but when you look at the cadavers, that's gonna be your goal. When you're looking at the brachial plexus, find the M, because what are they gonna wanna ask about? These branches. Why? Because those are that's what's gonna give you the problems, okay? Marmu, that's how you remember it. Musculocutaneous, axillary, radial, median, ulnar, Marmu, okay? Again, I put this like 5 times because it's good to know. All right, some good buzzwords. These are easy points on the test. If you have an injury to the surgical neck of the humerus, right? Humerus, bone right here. Surgical neck, you're gonna affect the axillary nerve, okay? What kind of symptoms are you going to get with that? Well, we already said axillary does 15 to 90, right? Because it innervates the deltoid. But also they like to talk about this sergeant's patch, where you get decreased sensation over the sergeant's patch. So if you think of the military, they have a sergeant's patch right here. You get decreased sensation over the lateral part of your arm. That sensation is innervated by the deltoid, so superficial muscles from the axillary, not the deltoid, the axillary. Also, what you injure, posterior circumflex humeral artery. The reason is that the anterior and posterior circumflex go around the humerus. So if you rip the humerus out, the most likely way the humerus is going to come out is anteriorly, right? Because the scapula is in the back. So if you pull it out this way and you have the circumflex artery around the humerus, you're going to rip it, right? Because it encircles it. So you want to remember surgical neck injuries, dislocations, stuff like that is typically going to be axillary nerve, and if they ask the artery, posterior circumflex humeral, right? It just tears it when it anteriorly dislocates. More importantly, they love mid-shaft fractures. The radial nerve dives deep when it travels down along the humerus. It goes very close to the actual bone. So in a sense, it's protected, but it's also going to be compromised when you talk about mid-shaft fractures. So anytime you get a mid-shaft fracture, you're worried about radial nerve injuries. And we'll look at a question in a second talking about that. The artery that goes with it is the deep brachial artery. Nerves are going to be more important in this sense, but it is good to have an artery that goes with it. All right, let's do this one. This is a good one.
Oops.
Okay, now they like this question because it's a little, you don't have the last one in the PowerPoint. Yeah, I'll go back to it in a second. It's a little tricky here because if you just think about it, here we go. The guy's unable to extend the wrist, fingers, and thumb. All right, so distal. We know extension has to do with the radial nerve, but he can extend the elbow. So what it seems to be is that extension above the elbow is okay. So what is the answer? Radial nerve mid-humerus. Now, if you think about that, well, the tricep is extension and it's going to be up in this area. How is the tricep not compromised? And the reason being is that the branch that goes to the tricep artery, I'm sorry, to the tricep muscle, the branch of the radial nerve that goes to the tricep, it comes off before the midpoint in the humerus, okay? So even if you have a mid-humeral fracture, the triceps will not be affected, okay? They like to put this on here because if you're just going to the elbow, you may think that the tricep would be compromised, but that branch comes off before the midpoint of the humerus, okay? So the tricep is going to be intact. So the only symptoms you're going to see are going to be distal, wrist, fingers, thumb. The elbow is going to be okay, again, because the triceps is going to be, the branch to the triceps comes off before the midpoint. Why can't it be A? So you always want to go with the most proximal point. Okay, so and A's dealing with flexion primarily. We're looking at extension here. Extension is going to be radial. Median is going to mostly do flexion. All right. So just one of those tricks. Just remember that the triceps goes off beforehand. What was the? No, you don't have the. I made these slides. Yeah, some of these. So this mid shaft, yeah. So you all these slides are posted. Y'all can go get these. They're in my PowerPoint though, right? Yeah. Okay. Yeah. Well, they have to be. I'm using them. All right. Yeah. So you can download these on the Scrubs page. So, yeah.
Yes, Charlie, gonna say hi.
Oh, she's Phoebe sleeping on the floor over there. All right. So again, before the mid shaft, just a question they really like to test. Extension of the upper arm is intact. All right. Another buzzword you need to know. Supracondylar, that's down here. If you have a supracondylar fracture, thanks, Kishore. If you have a supracondylar fracture, you're going to be affecting the median nerve. So when you talk about median nerve injury, you're talking about this part. We'll get to the hand in a little bit. So you're going to have problems with flexion. Medial epicondyle, another buzzword for you. You can see here. So this is the right arm. The medial epicondyle, any sort of injury there, you're going to have injury to the ulnar nerve. That's the medial epicondyle. That's right around the area where you hit your funny bone. If you hit your funny bone, you think about it, the sensory innervation. Next time you do, you'll feel it. You'll feel numbness on this finger and literally half of this finger, right? So you can rub on both sides of this and you feel it on one side and not the other. So if you can't remember on a test, just hit your funny bone and you'll remember. All right, this is from first aid. You could kind of see the sensory innervation here, where it goes. Good to know, especially in the hand. They like to test this. So radial nerve and the ulnar nerve, you're chopping, right? So the medial aspect of the hand. All right, they like this question too. Try this one. Cool. So yeah, this is like the only way they could ask this question, right? Because like this injury primarily, so to my knowledge, only happens in kids. They talk about parents swinging their child. So this ligament is lax, right? So if we look at the picture, the ligament is lax, and so the head of the radius can slip out, right? It's really painful at the time, but as soon as they set it back in place, the pain goes away. Okay, so this is just a common injury that happens in kids because the ligaments in their bones aren't fully formed. So it's called nursemaid's elbow, but definitely know that in context of the kid, right? All right, so just a couple of buzzwords to remember. The radius is going to attach to the capitulum. The ulna is going to attach to the trochlea. Now, when we look at these, when we're looking at the elbow, remember at the elbow, the ulna is going to be larger than the radius, okay? The radius is going to be smaller. As we move to the wrist, the radius is going to be the bigger bone and the ulnar is the smaller bone, right? Okay, so when you're looking at the wrist, the ulna is larger, radius is smaller. When you get to the wrist, this is at the elbow. Sorry, I don't know if I said that wrong. At the elbow, the ulna is larger, radius is smaller. At the wrist, the radius is larger and the ulna is smaller. But we'll look at the wrist in a second. All right, these are just a couple of tricky things that I came across. This kind of makes sense. The median nerve is going to turn into, because it's on the anterior side, it's going to turn into the anterior interosseous nerve. Radial nerve being on the posterior side, change into the posterior interosseous nerve. So they could put these on the question stem, and you need to be able to correlate which goes with which. What gets tricky is the ulnar artery technically splits into the anterior interosseous and posterior interosseous arteries, okay? So just be sure you can keep these straight in your head. All right, let's do some hand stuff. And kudos to y'all, because this is very difficult doing this without actual cadavers in front of you. Without being able to do, doing this in 2 dimensions in a book is not ideal. So we feel you, we were there too. Lindsay loves to draw on herself. All right, she's gonna point it out. Yeah.
Hey, I've had so many people message me after the fact saying that was some really good advice. And I have so many people in my term that like, yeah, I did that too.
Whatever works.
Yeah. You just have to make sure that you get it off before the exam or they'll think you're cheating.
All right, so point here is that we're looking at the 4th and 5th digits, right? And you'll see that the 4th and 5th digits are innervated by the ulnar nerve, and they come off that area of the flexor digitorum profundus. So this is another tricky concept that we want to look at. The flexor digitorum profundus is a tricky muscle, which is why they like to test on it. It actually is dually innervated. So half of it's going to be innervated by the ulnar nerve and the other half by the median nerve. So the medial 1/2, remember we're in anatomical position. So the medial 1/2 is going to be the 4th and 5th digits. It's going to be innervated by the ulnar nerve. Whereas the lateral half, right, is going to be digits 2 and 3 are going to be innervated by the median nerve. And as we look, so I saw before, the anterior interosseous branch, okay? So it's just one of those weird things. For whatever reason, it has 2 heads or 2 bellies and it splits. So meaning that's a good testing point for them because they can ask you 1 and it's half of the muscle. So this is how it breaks down. If you look at the flexor digitorum profundus, you could see that the ulnar digits 4 and 5, which are the medial side, are innervated by the ulnar nerve. And the lateral side, digits 2 and 3, are going to be from the median nerve. Now, they attach to the distal phalanx, okay? Flexor digitorum profundus, distal phalanx has the split, right? 2 bellies. Now, if you look at the flexor digitorum superficialis, it's going to attach, different muscle attaches to the proximal phalanx. Now, all of these are going to be, this whole muscle is going to be innervated by the median nerve, okay? So we could just go back and forth. You can see an injury to the median nerve will be worse than an injury to the ulnar nerve. Why? Because there's 6 points of flexion here that would be affected if you injure the median nerve, where just 2 are affected in the ulnar nerve, right? So let's go back to the question. Inability to flex the DIP joint of the 4th and 5th digit. So if we look here, this is the DIP 4th and 5th digit, right? So how would it look if you had a median nerve injury? Well, not only would you not be able to flex the 2nd and 3rd digit of the DIP, you wouldn't be able to flex any of the joints at the PIP joint, right? The proximal phalanx, okay? So they like to test on that. Be sure to have that straight in your head. All right, carpal bones, everybody's favorite. What's interesting here is that the ulna doesn't actually attach to any of these carpal bones. The ulna is wrapped around the radius. The radius is what attaches to all these bones. So there is no actual correlation between the ulna and the carpal bones. Like I said, there's this there's a ligament that connects the radius and ulna together, but all of these bones technically attach to the radius. So if you were looking at this, the trick here is, if you can, find the thumb. You could see that if for some reason they don't show the thumb, remember we said earlier, at the wrist, the radius is going to be larger than the ulna. At the elbow, the ulna is larger. At the wrist, the radius is larger. So you could find the radius, right? And then you orient yourself, thumb, radius. Now you can organize the bones. So this is how we do this. We go proximal thumb side. That's where we're going to start. Proximal, right? Thumb side, scaphoid, lunate, triquirium, pisiform. Then we go back, thumb side, and do distal, trapezium, trapezoid, capitate, hamate. So you read it left to right, okay? But you want to find the radius first, thumb side, and read it. The reason we do this is because we have this great mnemonic, the dirtier the better. Some lovers try positions that they can't handle. Everybody remembers that. So that's how you do it. Now, in testing purposes, unless they give you some sort of first order question and just point to one of the bones, they're going to talk about 2 of these primarily. And I have questions here for you. So try this one. Yeah, exactly. So we're talking about a fracture here. So typically you fall on your outstretched hand. The bone that's most likely fractured is going to be the scaphoid. And you could see that here. So let's orient ourselves. Which bone is bigger? This one. This is the radius, right? So radius is always thumb side, right? Always. It's got to be on the thumb side. So you know the thumb's over here somewhere. So you see this, it kind of looks like a peanut. Once you see the peanut, can't go back, right? So you see the fracture here. Now, the problem with this is that the radial artery runs right around here. So it's not, it may not initially be in the ER if you get this scanned, get an x-ray. It may not be easily detected, but if you injure the radial artery, you can get avascular necrosis to the distal aspect of the thumb side of the scaphoid, right? Because it runs right there. So you could injure the radial artery. So ideally you can get some sort of MRI to make sure that that's not compromised. But yeah, so fractured, we're talking about the scaphoid, okay? Now, same question, but we're talking about a dislocation. Which one is most commonly dislocated? Yeah. Good, yeah, y'all got this, right? So lunate, typically it's dislocated posteriorly, right? Because of just the way it's the bones are organized, it kind of pops out toward the back, right? So lunate is going to be dislocation, posterior dislocation. All right, let's try this one, and we'll go through these. All right, good. So the key thing for these Smiths versus Colles fracture I want you to focus on is where is the position of the distal fragment, okay? So what are we talking about? The distal fragment of the radius is angled forward or anteriorly. So you always define the fracture by the distal fragment. So if you were in clinicals rotations, you would say there is an anterior dislocation of the distal fragment of the radius, and immediately the attending would tell you that's a Smith's fracture or ask you if that what kind of fracture that is. So let's break this down. So posterior fracture. So we're talking about the distal part. So the distal radius in the hand technically, right? So if we have so we see the radius here. The fracture, the distal part is posteriorly displaced, right? So a posterior fracture, meaning the distal fragment fractures posteriorly. This is the distal fragment. It's going posterior to the radius. So let's look at this on an X-ray. If we find our radius here, you can see that this hand is posterior displaced. So you find the thumb, so the hand's down like this, right? The palm's down. And you could see that the distal fragment is posteriorly displaced, okay? So that's a Colles fracture. Now, if we look here, find our distal fragment, our palm's down, right? So palm is always anterior. So this is an anterior displacement. The distal fragment is displaced anteriorly, right? Anterior displacement. So we're looking at a Smith's fracture. So again, find your thumb here. So the palm's facing to this side, to the right. And you can see here that this is displaced anteriorly. This one's not as obvious as just one I found on the internet. But technically, if you looked at this, you would say this hand is displaced anteriorly. They wouldn't give you something like this. This is more difficult to tell. But they'll probably just give you just a scenario, right? But you're always worried about the distal fragment. All right, that's my dog snoring. She does not care about this. So, all right, this is a good one too. Phoebe, come see. Now she's mad. All right. Come here. No. Mm-mm. Yeah, this is definitely a tricky question. So takes like two concepts in one. All right, so let's break this down now. Anterior, so you have an injury to the anterior surface of the wrist. So we're affecting a nerve anterior surface. What two nerves travel on the anterior surface that we're worried about? The median and the ulnar, right? Now, how do we determine which one's which? The cut is down the surface of the flexor retinaculum, but not into it. They're not telling you that for fun. They're trying to differentiate the two. Remember that the median nerve travels beneath the flexor retinaculum. Okay, the flexor retinaculum is like a watch band, right? It doesn't really, it doesn't really stretch, right? So that's why the median nerve that travels underneath it, you get carpal tunnel. So if you overuse your hand muscles, if you're typing or writing or whatever, you get the tendons will swell and the flexor retinaculum doesn't really expand. So it'll pinch or compress the median nerve that travels underneath it. Now, the question is saying that we didn't cut into the flexor retinaculum. So that means the median nerve could not have been affected. So we must be talking about the ulnar nerve. So that's the first step, right? Then we have to determine, well, which of these involves the ulnar nerve? And I put this on here for a reason, because it's not that obvious. So first off, yes, median nerve is not affected, not into it, right? But what is not intuitive is that the ulnar nerve actually helps with adduction of the thumb. So the ulnar nerve, even though it comes off on this medial aspect of your hand, it does have a branch that comes off that helps with adduction of the thumb, right? So abduction, adduction. So if you have a problem with adducting the thumb, it could be an ulnar nerve injury. Now it's very tricky because when you think of the thumb, you think of the median nerve. This is a special branch that comes off the ulna. So adduction of the thumb is controlled by the ulnar nerve, which is the adductor pollicis. So again, when you come across these tricky little things, these are the things that they like to test on. So all of the other muscles that involve the thumb deal with the median nerve. This is just a good situation. And yeah, that's what I said. All right, so this is from first aid. Love this, you'll never forget this. I have it coming up though, we'll talk about it in a second. Right, but if you like first aid, the sooner you start looking at this, the better. All right, so thenar muscles, right? So under the thumb here, you have the oaf muscles, or the oaf muscles that all have pollicis in it as well, right? Because pollicis means thumb. So the opponent's abductor and flexor all deal with the median nerve, okay? These are your thenar muscles, plus the median nerve is gonna innervate the lateral two lumbricals, okay? And we'll talk about the lumbricals in a second. Thumb is lateral side, right, in anatomical position. So these thenar muscles, these lumbricals, the lateral two are gonna be by the median nerve, okay? So if this helps, L loaf or double loaf or whatever, to remember that. Now, don't get tripped up because the ulnar nerve technically is OF2, but they're all gonna have digiti mini-me for the pinky. No, I don't think you need to know the specific branch. I don't even know the specific branch. Do you know what it is? What is the branch? For the lumbricals or the
for the thenar muscles, like, you know, there's like a current branch and then there's
yeah, maybe so that the I don't know, you think he's sure? Do you know? No, yeah, no, they'll probably, because if you get an injury, they're going to talk about a proximal injury, right? They'll probably won't tell you like get a knife through the hand or anything like that. That gets tricky. They'll probably
I
talk
don't know,
about
it just
that.
seemed Grace. Yeah, it was in Grace.
Yeah, that's the recurrent branch. There's something special about it. Doesn't the recurrent branch of the median do like all of the thenar muscles?
Yeah.
Okay, yeah, that's probably good to know. Other than that, you should be fine. Yeah.
Thank you.
Just know that part. No worries. All right, so hypothenar, oaf as well, digiti mini-me, right, are going to be in it. Now it's also going to do the medial two, right? So digits 4 and 5, medial two lumbricals, right? But it's also going to do these interossei muscles. So what do the interossei muscles do? They help you abduct and adduct your hands, right? Like this. All right, so let's talk about the lumbricals, because this is the thing about medicine, nothing is black and white, there's always exceptions. So when you think about the median and ulnar nerve, you always think about flexion. When you think about the radial nerve, you always talk about extension. Well, this is one of those weird exceptions, because if you look here, the lumbricals, like we said, are innervated by the median and the ulnar nerve. They're going to help to flex the metacarpophalangeal or MCP joint, but they're actually going to extend the interphalangeal joints. Okay, this is the weird exception where the median and ulnar nerve are going to deal with extension. This is more, it's not super high yield, but I just don't want you to get mixed up because some of the Grace questions can talk about this. So this is a point, even though it's extension, this is going to, these lumbricals have to do with median and ulnar. So L lumbricals does the L like this, right? Like this. Okay, so yeah, we talked about that. Flexors, but they also have this extension, okay? So if you look at first aid, they talk about it as well. So I just didn't want y'all to get mixed up. So there's a good mnemonic, this dab pad mnemonic. So the interossei, remember all the interossei muscles are gonna be innervated by the ulnar nerve. They're gonna do abduction and adduction. Dab, dorsal interossei do abduction, right? Spread the fingers out, all right? And then pad, palmar interossei do adduction, bring them together, right? But just in case they ask you to differentiate between dorsal and palmar, dab pad. All right, and you also you have to have a a line to start the abduction or adduction, right? So they use the middle finger, and this is your line that you everything abducts and adducts around that finger. Okay, try this one. y'all are gonna get flagged on the exam for throwing up gang signs like benediction's hand, and like we still do it. Yeah, it's a problem. All right, good. So benediction attitude. Okay, so we're trying index and long fingers extended and the ring fingers are flexed when you're trying to make a fist, right? So you're trying to make a fist and the first and second fingers won't flex. So you know the first and second fingers that aren't flexing are controlled by the median nerve, right? So injury to the median nerve, okay? That's simple. Just think about it, right? If you can't flex the second and third digit, median nerve. If you have a problem flexing fourth and fifth digit, ulnar nerve. If you have a problem extending, you have a problem with the radial nerve. Now it does get tricky because we talked about those lumbricals, but in a general sense, that works out. So look at what they're saying. Let's do this one first. Pope's blessing, making a fist, all right? So if you're making a fist and you cannot flex, this is what the question we just did. Making a fist, you can't flex the second and third digit here, median nerve injury. Okay, let's do making a fist again. If you can't make a fist here, you have an injury to the ulnar nerve. Now it gets tricky with this, and this is why I included it in there when you do extension, because on the surface you would say extension is done by the radial nerve, but in fact those lumbricals are innervated by the median and ulnar nerve. So you do get injuries when you try to extend them as well. But I would bet that they would just talk about in context of making a fist, okay? So don't get too caught up with that. As long as you know these, you should be fine. You okay? Come say hi. All right, here she is. She's upset now. Say hi.
What's up,
All right,
Steve?
say hi. Hey, everybody. All right. All right, let's move on to the thorax and we'll take a break in a second. What they like to test in the thorax is this VAN bundle, vein, artery, nerve. You need to keep in mind the nomenclature or how they're going to ask this. The VAN runs inferior to the superior rib. So this is the superior rib, this is the inferior rib. The VAN's going to run inferior to the superior rib, okay? But they can also ask you, well, where would you, if you had to do a thoracocentesis to pull fluid out or whatnot, where would you put the needle? So since the VAN runs inferior to the superior rib, you want to insert the needle superior to the inferior rib, right? Make that make sense for you. Superior to the inferior rib is where you put the needle, because you don't want to affect this VAN right here. You don't want to hurt the patient, all right? So they could ask it either way. So needle goes superior to the inferior rib. All right, let's do this one. All right. So this is our clue here. They're talking about paravertebral lag. Now, clinically in the ER, they do it mid-axillary. Why? Because, well, when the patient's in the ER, it's much easier to stick a needle and much better for the patient long-term to stick a needle mid-axillary than paravertebral in their back through all those back muscles. But just because it says it here, what's that going to correlate? It's going to correlate to the 11th, in between 10 and 12. So I'll show you how this works. So technically the paravertebral is the most dependent area, right? The fluid's gonna sink down there. But ideally, like I said, it's just easier to do it mid-axillary. So but they could ask you any of these on the test, right? Mid-clavicular is 6 to 8, mid-axillary is 8 to 10, paravertebral in the back is 10 to 12. So just remember 6 to 8, 8 to 10, 10 to 12, right? So the idea is that you're trying to get this fluid that's in this dependent area, the most, the gravity-wise, the most dependent area, without affecting the lung. So that's where it's going to collect. And that's called the costodiaphragmatic recess. All right, they like this for whatever reason, so we'll look at this too. We'll take a break in a second. All right, so what is the most important factor? So the most important one that we talk about is the diaphragm. By all means, the diaphragm, it contracting and relaxing is going to cause that negative pressure to where you're able to breathe in, right? So your negative pressure allows air to go into your lungs. But this allows us to talk about these other movements. So remember, the pump handle is just going to be anterior posterior. So technically, all of these are going to increase negative pressure, right? By expanding the volume, the pressure is going to go down, negative pressure. So you get air goes in. And when you breathe out, you're decreasing the volume, increasing the pressure. So air goes out. We'll talk about that more when we get to respiratory. But this anterior posterior, right? You can see here, this is that pump handle. Whereas the bucket handle goes to both sides. So this is our lateral movement of the ribs. So the ribs are going to go up, it's lateral movement. But by all means, the most important thing, the diaphragm, it contracting and relaxing. Remember, when it contracts, it makes that negative pressure. So you could breathe in, and when it relaxes, it pushes the air out, okay? So that's going to be your most important one, but you want to keep in mind these as well. Okay. Try this one. All right, good. So this is a good way of testing the dermatomes, right? Because so what happens is you get chickenpox, which is varicella zoster virus, VZV, and afterwards the virus lays dormant, all right? And it actually lays dormant in these dorsal root ganglion. A ganglion, by definition, is a cell body outside of the central nervous system. So these little viruses, they just live dormant. They're not doing anything for a while, and eventually tend to people that are immunocompromised or elderly people, they tend to be immunocompromised. You can get reactivation of this latent virus. And what's classic about it is it will reactivate, and because it's in that specific dorsal root ganglion, it will go to one dermatome. So any question they ask you when they talk about this virus that affects, it looks like a strip, right? It's like a single dermatome. So if you had the T3 got reactivated, the dorsal root ganglion of T3, you would see this strip. Now it'll only be on one side of the body because you have DRGs, dorsal root ganglions, on both sides. So they'll say it's a strip-like fashion and it stops at the midline. Okay, look at this. What would y'all say this is? So nipple lines, T4. So I would say this is about T3. Look how it stops right along the midline. Classic, right? This is shingles, herpes zoster, okay? And you get this. A lot of people that don't mount a strong response to the chickenpox, they don't have a bad chickenpox infection, they don't mount a strong immune response to it, so they can get reactivation of it commonly. That's why they say if you did have a strong reaction, you got really sick to COVID, you're more likely to be protected against it just because your body had to mount a strong response to it. So this is one of those classics things they like to test on. It'll come up again and again. but it allows them to test the dermatomes. All right, lymph nodes, everybody's favorite. All right. So this is the one that they really like to test on this one because there's this complex, this axillary complex. So whenever you get breast cancer, typically they talk about, well, okay, first off, what is the first node called? Does anybody know? The first node that would drain from a tumor?
Seminal or sentinel?
Sentinel node, yes, sentinel node. So for breast drainage, 75% goes to the anterior axillary or the pectoral, and then 25% goes peristernal. So the best answer here would be anterior axillary. The way I think of the lymph nodes is they're like roads, right? And they go to a central hub. So the lateral axillary, which comes from the arm, the anterior axillary, which come from the pectoral region of the breast, and the posterior axillary, which comes from the back. A lot of times they talk about stabbing in the back. Where would the infection be? Posterior. They all drain into the central. This is our highway. These roads drain into the highway, and then from the central, they go up to the apical, okay? You can see that here. Anterior, posterior, lateral from the arm, drain to the central. From the central, they all go up to the apical. They like testing on that. And you could see this a lot of times, you know, they have to take out the sentinel node. They'll take out any nodes that are affected, you know, specifically with breast cancer, because you don't want the cancer to metastasize through the lymphatic system to other organs and whatnot. And if you have to take out these lymph nodes, a lot of times you can't get this drainage, this fluid drainage. So edema, meaning fluid buildup, this lymphedema, this is caused by this lymph node extraction, okay? All right. Let's take a 5-minute break and we'll do pelvis and lower limb and some of the development stuff. Popeye arm, yes, indeed, exactly. I don't know, it's not muscle, it's all fluid, but sure. All right, 5 minutes. All right, couple questions. Yeah, so any sort of breast drainage that they'll talk about, the sentinel node they're referring to is the anterior or axillary or sentinel. Those are all work together. The sentinel node, it could be any node, it's just where the cancer is, the first node that it gets to, okay? So in regards to breast drainage, the axillary is the first node that they talk about. Yeah, so any sort of reaction you get, like your body's reaction to, say, chickenpox or whatnot, you're gonna the worse you feel technically, the more of an immune response you get. So the more protected you are against it in the future, the more memory cells you get. Yeah, and let's see. The diaphragm is contracting when you inhale. So that when you contract the muscle, it gets smaller. So then you get you get decreased pressure, right? You get a vacuum when you contract it. So the space gets bigger, you get a vacuum, and then you get air in. And when it relaxes, it gets bigger and it pushes air out. Yeah, it's kind of counterintuitive when you think about it. But yeah, when you contract, you're inhaling. And when you relax, you exhale. Just practice. Kidding. All right. So yes, technically, if you put dye and you saw the lymph drainage, 25% of the dye would go peristernal, but the vast majority will go anterior axillary. Contraction increases the capacity. Yes, right, for sure. Y'all are welcome. This is a Trot slide. She's the best. We don't have her anymore. Yeah. So we mentioned this earlier, but in case anybody came in late, we'll finish the lower limb today and the development stuff, and we'll do all of the bone synthesis, cartilage stuff next weekend. We'll shoot for Saturday. That way y'all have a little bit more time before I think your exam is Wednesday, so that'll be good. It'll be good to review it. So we'll cover the rest of the MSK stuff. If you haven't seen some of that synthesis bone stuff, it gets a little confusing, but we'll walk through it next weekend. Yes, 75% goes anterior axillary. That's together. It's called the anterior axillary node. Sometimes they just refer to it as the anterior node, but anterior axillary, yeah, that way. All right, if y'all are ready, suppose we'll get this done. All right, abdomen. Abdomen and pelvis are very much, as you can imagine, are very much organ derived, right? So the muscles of the abdomen and even the pelvis aren't super important right now as much as the upper limb and lower limb, when you study GI and you study reproduction, y'all are going to go into that in a lot more detail. So we're just going to kind of touch on a few things, kind of like thorax, right? We're touching on it, but the vast majority is going to be talked about when you do organ stuff. All right, try this one. This is very high yield. Actually, this is kind of high yield. Sorry, I saw that the hernias are high yield, but we'll get to that in a second. All right. I don't remember these, but I put this here because there's a good way to remember this. This is it. Yes, ice tie. So the ice goes. The ice comes from the tie. So internal spermatic fascia comes from the transversalis fascia. So as that fascia just kind of like if you think of like a visqueen or like a plastic layer around muscles, it doesn't really expand as much. It's kind of like the retinaculum, just kind of surrounds muscles and keeps everything compact. So this fascia layer is going to go into the gonadal fascia, right? So the transversalis fascia of the abdomen goes to the internal spermatic fascia. Internal oblique muscle turns into the cremaster muscle, and the external oblique turns into the external spermatic fascia. So just use this ice tie thing if they ask you about it. Yeah. All right, this is what I was thinking. This is very high yield. Hernias are very common. Okay, so there are two hernias you want to be concerned with in regards to the abdomen. You have the direct and the indirect, right? So they tell you it goes through the deep inguinal ring. If it tells you deep inguinal ring, you know automatically it is an indirect hernia. The direct hernia goes through the superficial inguinal ring. The indirect hernia goes through the deep and the superficial. So, let's see if I have a picture. Yeah, so an indirect is lateral. What is super important, did I put, no. Oh yeah, I did it here. What's super important is these inferior epigastric vessels. That's your line of demarcation, okay? So anything lateral to the inferior epigastric vessel is going to be indirect. Anything medial to it is direct. Think think of direct as it's a direct line of sight, right? It doesn't have to travel very far. It just goes through the superficial inguinal ring. Indirect hernias is lateral to these epigastric vessels, and it has to go through the deep ring and through the superficial ring. So when you talk about direct, it goes through the superficial ring. Typically, this is a traumatic injury, an acquired injury, so like strain, picking up a heavy object, whereas indirect hernias are typically congenital. A good buzzword, patent processus vaginalis. If it's patent, it means it's still a hole that allows the bowels, the intestines to go through it. So keep those in mind. I'll get a question on that. All right, try this one. This came up on our most recent exam. If y'all are not on the meme page, there's like a SGU meme page. I need to join it. This reminds me of it because y'all saw the Bernie Sanders where he was sitting on the steps with his mask on. Somebody put Bernie's point. It's funny if you see it, but Bernie's point at where it is on the body for this. So join the meme page. You can find it. So yeah, so the McBurney's point is 2/3 from the umbilicus to the superior iliac spine. Okay, so if you look here, umbilicus, superior iliac spine, anterior superior. So it's 2/3 the distance, right? And that's McBurney's point. That is the point of where the appendix is. Okay. I put this in here. I don't have a question for it, but just remember this linea alba is going to be in, it's going to be separating anything in the middle, but this arcuate line, you can define it by anything above the arcuate line, the muscles split around the rectus abdominis. So half of the internal obliques will split, external obliques go anterior to it, transversus abdominals go posterior to it. But once you get below the arcuate line, all the muscles go in front of it. You may come across a question in grades about that. All right, try this one. All right, so if there's a reflex, you need an afferent limb and an efferent limb, like a sensory limb and a motor limb. So when we look at this, efferent meaning motor is going to be the genital branch of the genital femoral artery. Okay, the afferent branch is what? Which one of these is afferent? A, right, exactly. Ilioinguinal. Premaster reflex, yeah. So ilioinguinal and then genital femoral will make the testes go up motor-wise. All right, and this is kind of where they lay ilioinguinal, iliohypogastric and ilioinguinal kind of like they come about out of, is it muffled really? Do I sound bad, Lindsay? You're not listening.
Say that again?
Does it sound bad? Somebody said I sound muffled.
You sound muffled, but I mean, I can understand you, but it is muffled.
I don't know why. I'll give you 1 second. Let me just reconnect these and see.
All right, we'll try it this way. Right, okay, we did this one. All right. This kind of just goes into the different branches. Okay, try this one. All right, so the point being, a lot of times there's an occlusion, yeah, inferior vena cava. So if you have problems with the portal vein or traveling through the liver, a lot of times you can go through the ascending lumbar. That's just a track. This is a low yield question, but it could come up. The lumbar plexus nerves, yeah, probably so. I think there was a slide that had them, but just in regards to the clinical stuff, I don't think it's super high yield, but it may be good to know. I don't want to say no. All right, and this is just a bad drawing, but it kind of just shows the azygous system going through. The accessory hemiazygous comes from the left side of the body, and then the zygous vein travels back up. All right, so let's look at the pelvis. Try this one. I would just know in regards to the lumbar plexus, like know what the roots are, like what roots correlate to which nerves that branch off of it. That should be enough if they do ask you questions about it. All right, so these muscles are going to relax to allow the child, the baby, to be delivered, but the one that's unaffected is your true conjugate diameter. So this is going to come back up in reproductive, but just in case they ask you, you have this conjugate, this purple line here that you can see, and then it's basically your anterior posterior. Okay, so just in case you want to know, another important point here is that the narrowest of areas is going to be this interspinous diameter. So when they do ultrasounds and they look at the baby's head, they also measure this intraspinous distance, because if for some reason you get macrosomia or the child is too large, you may have to do a C-section, okay, depending on the length of this intraspinous diameter. All right, try this one. Good, yeah, they like to test this. Pubococcygeus, it makes the ring around the rectum. You can see that here, or sorry, a ring around the, around the rectum. Nope, around the vaginal canal and the urethra. Sorry, not the right. Sorry, I'm looking at this wrong. Okay, nope, you see the whole pubococcygeus does go around the urethra and the vaginal canal, but it also does surround the rectum. So you can get fecal incontinence with this as well. Sometimes they'll use puborectalis. That is part of the pubococcygeus. So if either pubococcygeus or puborectalis is there, that could lead to both urinary and fecal incontinence, okay? So that's what you want to look for in that situation. All right, this is a tricky one. Try this one. Yes, both urinary and fecal incontinence. Yeah, for sure. I think if they ask, they probably talk about fecal incontinence for this test. All right, so this one is opposite of what you would think. So if we lift the left foot off the floor, how do we have a positive Trendelenburg sign? So remember that in this situation, the muscles on the right, the gluteus medius and minimus on the right, are going to help to keep the left hip elevated, okay? So if you look here, if this left leg and this hip drops, you have a problem on the contralateral side, okay? So this muscle is going to be what helps to keep the hip stable. So just make sure it's kind of counterintuitive. It's the muscle on the opposite side that would be indicative here. because the muscle, you're not using the muscles that you're lifting the leg, the side that you're lifting the leg on, right? To keep the hip stable. You're using the muscles that are stabilized on the ground. So it's opposite. And that's called the Trendelenburg sign. All right, let's go to on to the lower limb. Try this one. All right, some varying answers here. So the one that's compromised that you need to keep in mind when you talk about the femoral head is this medial circumflex femoral artery. That's what's going to be compromised. Okay, so when we look at these, you can see this is a normal structure. You could see the acetabulum and the acetabular fossa here and the femoral neck. Now, they talk about the Shenton's line. Again, it's kind of like when we were looking at the vertebrae, right? You would expect a line to be concise or continuous, right? If you have some sort of injury here, look at this line. It's messed up, right? You can't make a straight line across. And you could see this shortened femoral head because you had a intracapsular fracture. And these intracapsular fractures are worse than extracapsular because of the way the arteries transverse it. So the one that's compromised typically in this area is the medial circumflex femoral, okay? So this is what I was saying, this intracapsular, these are the bad ones. Not that extracapsular are good, but the intracapsular are the worst one because you can get compromised blood supply, okay? Avascular necrosis basically just means the blood supply is messed up, so you're not getting blood to the distal fragment, so you can get necrosis of the tissue. And then the branches that go off, the smaller branches, are the retinacular branches. Are those little arteries. But the main artery that's going to be injured is the medial circumflex femoral. Okay. Knee exam. All right, you need to be able to read these on the MRI. So we're going to talk about them. ACL versus PCL. Okay. This is from first aid. All right, do this one. Ascending lateral, maybe that would work with that. I would definitely think they would put medial because the lateral comes into play in a little while when we talk about the knee. All right, good. So we're talking about, when we talk about the drawer test, we're talking about the distal fragment again, which way does the distal fragment travel? So a positive drawer sign means the tibia can be displaced anteriorly. Does it say what kind of injury? Do y'all know what? Oh, here it is. Yeah, an ACL injury. ACL anterior means anterior displacement, anterior drawer test. What that means is the ACL prevents the tibia from being able to be displaced anteriorly. So if you have an injury to the ACL, you're going to be able to move the tibia forward. Okay. Yeah, so you can see that here. This is the ACL. ACL is going to be running more anterior than the PCL, but it is kind of tricky to point this or to be able to locate this. But again, and we'll look at that on the MRI in a second. PCL is going to run behind it. So PCL is going to help prevent posterior displacement of the tibia. Makes sense. Anterior, ACL, anterior, PCL, posterior displacement. All right. So, and this is the same thing. We're just doing the tests here. And this is a good way I like to look at it. So the ACL runs, if you start superiorly, it runs from posterior to anterior. The PCL, if you start superiorly, it runs anterior to posterior. So if we look at the ACL is preventing, you see if it was like a rubber band here, it's preventing you from pulling this tibia too far forward. So if you have an injury to this red line, the ACL, you'll be able to pull this tibia forward this way, okay? Same thing goes with the PCL from the other side. So make sure you could do this because they could give you this on a test. So ideally, you'd be able to identify this one's a little tricky, but you should be able to find it, right? So remember, let's go back one. We said that the ACL runs from, if you start superiorly, from posterior to anterior. I outlined it here. You could see the ACL running. If you start superiorly, it runs posterior to anterior. Again, it's preventing this displacement, this anterior displacement, okay? So you can see the ACL here, okay? This one's a little bit clearer, right? You could see the posterior, the PCL, it's running, if you start superiorly, from anterior to posterior, right? PCL, it's preventing posterior displacement, okay? So sit with these and make sure you can point these out, okay? I'm gonna find it, be able to isolate it. All right, hope that made sense. Try this one. Oh, in regards to T1 versus T2, that's a little more difficult. Yeah, I don't even know, to be honest with you. It's hard to say. Oops, wait. Yeah, wait. Oh, no, sorry. I gave you all the answer. Okay, so ACL. So this is called this unhappy triad. Typically, they talk about an athlete getting struck in the side, the lateral side of the leg. So you typically have, in this unhappy triad, you have MCL injury, an ACL injury, and either a medial meniscus or a lateral meniscus. Different books say differently, but this is this unhappy triad. So when you have one injured, you often have all three injured. And you could see this here. This player got hit on the lateral aspect. Now keep in mind, well, let's first orient ourselves. Which side's the lateral aspect? Well, the fibula runs on the lateral side, right? So the point is, just like here, player got hit here, which means you stretch the ligaments on the medial side, right? So you tend to get an ACL injury, an MCL, and then the meniscal tear as well. So not good, out for the season. All right, just in case they ask about the bursas. So a housemaid's knee is subcutaneous. So housemaid, I have to think about this. Liz, like if a housemaid's cleaning the floor, like she's further on her knees. Like think about it, a housemaid versus a clergyman, like somebody praying on their knees versus someone scrubbing the floor. Like the housemaid's knee tends to be higher up because you're leaning over on your knees, whereas clergyman's kind of leaning back. So it's infrapatellar bursa, okay, right here. So clergyman versus the housemaid's knee, just in case they ask you. And also, isn't there, oh, the Baker's cyst is always posterior, in case they ask you about that. So just a little bit more about that. Now, these are going to come important. I don't think they covered this very well in our lecture. So valgus, remember, again, this is a common theme. We're going through this distal fragment thing, right? So the distal aspect. That means the distal fragment is displaced laterally. And I know there's a lot of tricks to learn this, but if you just remember this, then you can always get it right. Varus means the distal fragment is displaced medially, okay?
So I have a way to remember that if y'all want it. So valgus, that means the joint is glued together, valgus, like a gum. So the joint is glued together, and then that means the lateral part, or the distal fragment is lateral, because, you know, if you're putting your knees together, your leg is now displaced laterally from the midline. And so that's how I remember valgus versus valgus, varus. And then, so you can, whatever joint it's at, just think of it that way. That's how I learned it.
And just remember, you have to be talking about the specific joint. So if we're talking about the hip, don't think about the knee joint. Just think about the lateral fragment from the joint, like directly distal to it, okay? So vera means at this joint, this distal fragment is medial, so you'll get like knock knees, right? Whereas this, you'll get not, bow legging, where the legs will be displaced apart. Valga, outward, distal fragment outward. Right, so genus for the knee, genu means knee. We look here, Varum means, so if we're talking about the knee, which way does the immediate distal fragment go? Medially, varum. If we're looking at the knee, which way does the immediate distal fragment go? Laterally, valgum, valgus, right? Same thing with the toe. If we're looking here, this is the joint of interest. Which way does the immediate distal fragment go? Laterally, right? Valgus. Which way does the immediate distal fragment go? Medially, valgus. Okay. All right, try this one. And this is why this is the question why I don't want you to get confused with the medial femoral circumflex at the hip and the knee. All right, so this is a tricky one, but if you have some sort of compromise to the popliteal artery, the lateral femoral circumflex runs on the lateral side of the leg is going to give you collateral blood supply, okay? So keep in mind, if you're talking about some sort of injury to the head of the femur at the hip, you're thinking medial femoral circumflex. If you're talking about some sort of injury to the popliteal artery at the knee, you're talking about lateral femoral circumflex. So you can see all these branches here, but this lateral branch can help give blood supply if you get some sort of injury to the popliteal, okay? All right, try this one. So this is one of those questions where that I was saying earlier, they could ask you two different ways. They could say, how is it supposed to look? Or what is the deficiency after this injury? So they're saying injury to the tibial nerve, right? How's it going to result in? So what does the tibial nerve help you do, right? It helps you to plantar flex, right? So if you are supposed to be able to plantar flex and you can't anymore, then how's the foot going to look? Dorsiflexed and everted. Now there's a caveat to that because the tibial nerve also does a component of inversion. There's no direct nerve that does inversion completely. The tibial nerve and the, what's the one on the front? The fibula, nope. What is it? The common, not common fibula, the deep fibula. That's it, right? Deep fibula.
What are you trying to figure out again?
There's a superficial.
I think it's superficial fibular. I think the one you're trying to say.
Deep, but deep fibular does inversion too, right?
Yeah, inversion. Yeah,
Okay.
it's the deep one, and the lateral or eversion is the super.
Okay, so yeah, I'll clarify that. So deep fibular and posterior tibial, both are going to have a component to inversion. Superficial fibular is going to do eversion by itself. Okay, so I think I have a slide coming up, but tibial nerve, just remember, it's going to help you plantar flex, to stand on your toes, to press on the gas pedal, right? And it's also going to be a component of inversion, right? Moving your foot medially, like towards the midline. Okay. Yeah, this is it, right? So yeah, deep fibular. And so this is, what leg is this? This is the left leg, right? Because we see our fibula on the outside. So the deep fibular and the tibial nerve are going to help to do inversion. whereas the deep fibular is going to do dorsiflexion and the tibial nerve is going to do plantar flexion. Then the smaller one, the superficial fibular, all it's worried about is eversion. So just be careful on the test if they ask you what's supposed to happen or how the deficiency affected it, right? They can say, what can the patient not do now because of the injury, or how will the patient present with the injury? Okay. So I think, like, if we go back to this question, the easiest way to do it is say, okay, tibial nerve, what is it going to do? It's going to plantar flex and it's going to invert. That's knocked out. So if we can't plantar flex and invert, we're going to be dorsiflex and everted. All right, try this one. This is tricky, so be careful. Okay, so let's check this out. So this is how the patient presents. The patient is presenting with a left foot drop. So what can the patient not do? The patient can't dorsiflex. Foot drop is basically you're in a plantar flex position. So the patient cannot dorsiflex or lift the foot up because they're in a foot drop position. Which one of these does dorsiflexion, right? Now here's the trick, and this is why I put this on here. Paresthesia and sensory loss over the dorsum and the left foot and lateral leg. What nerve does that? Superficial, right? How can they both be an answer? Well, you have to find the branch point, and they both come off of the common fibula. Right where the at the head of the fibula, right at the knee, the common fibula comes around the outside of the fibula and then branches into the superficial and deep fibula. So the point here is, don't jump the gun and see left foot drop and say, oh, it's deep fibula, because also look at that sensory innervation. So you have to go up to the branch point. If both nerves are affected, you caught them where they the most likely consequence is you caught them before they branch. All right, cool. And again, if you think about this, this graph, though it's simple, helps me kind of organize it. Green and blue help to invert. Inversion is moving the foot this way. This red, this lateral compartment, helps to evert. This green, which is the deep fibular, helps to dorsiflex. And tibial is going to plantar flex your calves, right? Stand on your tippy toes. All right. Foot stuff. Let's try this one. All right. Got a mix of answers here. All right, let's take a look. Now, we're talking about this flexor retinaculum. Same thing as in the wrist is in the ankle. You have this tight band around it. So if you remember the mnemonic Tom, Dick, and Harry, right? The T is for tibialis posterior. That's how they run, okay? So it's kind of a weird question, like why do they care? But it's just testing to see if you know what travels in that retinaculum. So it's, yeah, it's Tom, Dick, and very, very nervous Harry, artery, vein, nerve, and then H, right? So you could see this here. Yeah, and it kind of tells you how they run. I think I have a better picture. Yeah, so look, this is that retinaculum, medial tarsal tunnel. And that's where everything runs, but they run in the same pattern, right? And you could see that here. So this is a good way of looking at it, right? This is the big toe medial aspect. This is that retinaculum here, and you see how they run. So tibialis posterior, Dick is digitorum longus, flexor digitorum longus, and then Harry is hallucis longus. Hallucis is for toe, or big toe, right? So yeah, it's just good to know that. It's a good, easy mnemonic to remember those. All right, as for sensory innervation, again, we talked about this earlier with the back, but just make sure you understand that not only can they ask you, if there's an injury between L4 and L5, what nerve is affected, but they can ask you what are the downstream consequences of it. So L4 goes over the large toe. L5, you see how they kind of wrap around, goes through the middle toes. S1 comes and does the side of the foot. Okay, so they could tell you there's some sort of sensory loss there, and it can correlate to that. So be careful. Compartment syndrome, this is a medical emergency. Basically, you get bleeding into the muscle, right? And I told you this fascia kind of surrounds the muscle and it doesn't expand. So if you get bleeding into the muscle, sometimes there could be so much pressure that it actually collapses the artery. So you can't get blood out of there. Then it's a medical emergency. What they do is they surgically go and cut the fascia and allow that muscle to expand, and then blood flow can resume. But if not, again, a common theme, you can get this necrosis of the muscle because you're getting stasis of blood. All right, bones of the foot, right? You can see these here. This is kind of memorization, but we'll look at some of the clinical correlates. We've all sprained our ankle before, inversion, eversion. Typically, classically, it's an inversion injury. Remember, if you invert your foot, you tend to tear the outer aspects or injure the outer aspects of the limb. Okay, so we're going to look at a couple of those here. Try this one. Good. I tried to trick y'all and I didn't put the most common injured one. It's the second most common injured, but yeah, good, yeah. Calcaneofibular, right? Most common one injured is anterior talofibular. They make it easy. It's from the talus bone to the fibula, right? That's the one most commonly injured, but calcaneofibular is number 2. So you can see that here. That's where the injury is. And you could track where the insertion and or insertion and origin and insertion are in relation. But yeah, those are the most 2 that are commonly injured. Ankle sprains. For some reason, I remember a weird question, them asking like, what was the lowest, like the most distal ligament? If you look here, they're called calcaneofibular. Yeah, for some reason, I remember that being a weird question. Okay, so yeah, you can see how they kind of, everything attaches there. All right, so this gets a little tricky, but it does kind of correlate to the hand, which obviously we're all animals on 4 legs at one point, so there is a correlation to the hand and the foot. But these lath muscles you can see here, adductor hallucis, flexor digitorum brevis, flexor hallucis brevis, and the first lumbrical, they're all innervated by the medial plantar nerve, okay? So that's a good little way of remembering that, those lath muscles. And then a lot of the other ones are innervated by the lateral plantar nerve. So same thing you can use here, this pad and dab to remember it, adductors versus abductors. And these are all going to be innervated. As the ulnar nerve innervated the ones of the hand, the lateral plantar nerve is going to innervate these interossei muscles of the foot. Right? Perfect. All right. So when you get older, some of the, so we'll get into this when we get into cardio, but the veins actually have valves, right? So they're like segments because you're kind of going against gravity, right? So you get to these valve points. Well, when you get older, some of these valves can be compromised. So a lot of these larger veins that have valves, the valves are compromised and you get blood flow to these superficial veins. And this can lead to varicose veins. So you tend to see this in older people, but it's difficult because these superficial veins get dilated and it's difficult to pump blood. But it primarily is concerned with these deficient valves. All right, dermatomes, these are going to be important for you to remember, specifically like L1 is the inguinal ligament. Let's see, L4 is the knee and the medial side of the great toe. S1 is going to be, well, in regards to reflexes, it's going to be your Achilles reflex. I think I have a slide on that. But just be able to notice these. I have a question too. Yeah, these are going to be more important, right? So dermatonal, T4 is the nipple line, T10 is the umbilicus, L1 is inguinal ligament, L4 down on all fours is the knee, S2, 3, and 4 keep the penis off the floor, right? See that here. Good. Reflexes, C5 and 6 pick up sticks, right? So biceps, C7 and 8 lay them straight. So triceps, L4 is your patellar reflex, S1 is your Achilles reflex. And the good old anal wink reflex, S3 and 4, winks galore. Oh yeah, and we talked about premaster. L1, right? Remember the ilioinguinal is afferent, genital femoral branch of the genital nerve is the efferent branch, all right? So these are gonna come up again and again, so it's just good to try this. All right. So this is seems like a weird question, but they like to test it because this deep fibular nerve really only gives sensory innervation in the webbing part of the first and second toe. So they like to test on it. It's just weird. You can see this little yellow area. So if you drop a knife and you don't hit your foot, you might right there between first and second. They like to test on it. But this is a good, I like this little diagram here. You see cirrus on the outside, saphenous is on the inside, lateral plantar, and medial plantar. Right. And again, a little bit of the same stuff. So not only muscle innervation, but the sensory loss. Ideally, they'll give you deficits in both motor and sensory, but if they don't, you need to be able to identify either or. All right, limb development, last bit. And then Lindsay's got some questions for you guys. The main thing I want you to focus on here is what if there's a deficit, why did the deficit happen? You don't really need to know. We talked about this before, the whole jargon about how everything forms. We're looking at deficiencies, clinical correlations, and what was the problem there. All right, so just some basic definitions. Scleroterm correlates to vertebrae and the ribs. Myo meaning muscle, and we know dermatome has to do with the skin, right? All right, probably star this one. For some reason, they like to test on this. If you think if you're used to play Sonic when you were young like me, Sonic had a mohawk, right? So anterior, posterior. I used to think they actually named it after the game, but there is actually a Sonic Hedgehog animal, which kind of sucks. I thought they named it after the game, but whatever. He had a mohawk, so you can remember that is anterior, posterior. Keep in mind, they could ask you this on the polarizing activity as well. Proximal distal has to do with this apical ectodermal ridge, and they could even ask you this dorsal ventral stuff too. So just know this graph. All right, and then the main thing here I just wanted to point out is limb buds tend to form at week 4. Other than that, probably won't get into too much detail there. We're going to get into this next week, so let's just wait on that. All right, try this one. All right, good. So what is this condition?
Syndactyly?
Yeah. Bonus points. What kind of syndactyly?
Cutaneous?
Yeah, right, exactly. Because you're supposed to have 14 phalanges. So if you had less than that, it might have been osseous syndactyly. But because you have 14, you know that the bones didn't fuse. That's a little bit tricky question, but incomplete apoptosis can lead to webbing, right? Because the idea when we're a fetus, we all have webbing in our fingers, like Aquaman, right? But you have apoptosis, which actually forms the digital rays. So if you don't get apoptosis, you can get syndactyly. Yeah, so if it's osseous, you would get less than 14. There's 14 because of the toe. All right, here we see here, this is syndactyly. Kind of hard to tell. I mean, you can see the skin's fused, but maybe the bones are fused there too. You'd have to get an x-ray. And you can see this looks like a bony fusion here. But yeah, so just be careful with that. Polydactyly, poly meaning extra, get extra toes, stuff like that. Some nomenclature, they'd like to say supernumerary extra, right? Now, disruption of the anterior posterior pattern. What could they tell you? What is this? Problem with what gene?
Hox gene?
It could be Hox, yeah, but I was thinking.
Sonic Hedgehog.
Yeah, Sonic Hedgehog, right? Because remember we talked about Hox has to do with more of the, yeah, well, okay, so let's put it this way. I would, if they put both there, I would put Sonic Hedgehog, but Hox has to do with the repetition, like, so like the vertebrae. So if you're thinking extra digits, yeah, but I think more of like in vertebral problems, you can get a Hox because it's like the repetition pattern. But for this, if they specifically said anterior posterior pattern, you're thinking because Sonic Hedgehog is responsible for that, right? Club foot. How do I say this, Lindsay? Wait, this one. It's I couldn't.
I don't know. I look at the nicey like talipes, something like that.
Okay, it's from Harry Potter. I don't know. Whatever. But anyway, they could put clubfoot or they could put talipes equinovarus, right? So just know that those mean the same thing. This is this inversion, but you could get this. Oh, I didn't. So what syndromes did we talk about that can lead to clubfoot? Do y'all remember? Oh, those trisomies. Believe it was Edwards. Rickets can actually lead to bowing of the legs. This isn't technically bowing. This is clubfoot or like rocker bottom. I guess rocker bottom feet would be a better terminology for Edwards. This is more of a clubfoot. I don't actually know if they're the same thing because this looks kind of like a rocker bottom foot. I'd have to look that up, but yeah. Okay. All right, try this one.
Make sure that you do go over the embryo section in grays, the assigned questions, because that will hone you in on how they're going to describe it. Because, you know, there's a lot of like layman's ways to describe these pathologies for embryo, but they're going to pick out that one phrase that describes the actual embryologic disruption. And so make sure that for each and every pathology, you have that one phrase that you can zero in on. This is what this is. And grays is really good at helping you do that because it'll describe it like exactly how it's supposed to be, and find that phrase on each of the slide because that's how they're probably going to test it.
All right, so one limb shorter than the other by definition. This is meromelia. Amelia, A before it means no, right? So no limb development. Meromelia means deficiency. Since we did say limb development starts at week 4, you'd expect amelia prior to that, meromelia a little bit after, right? So there you go, the 5th week. A lot of times that some medications, thalidomide, I believe, can cause this. They don't usually prescribe that too much anymore. But yeah, so that's good to know. Different correlates that form. Lobster claw deformity. I don't know if that's a politically correct way of saying it these days, but it's there. Let me make it up. So cleft hand or cleft foot, ectrodactyly. Yeah. But again, if they ask you a question and since somebody comes in with this, one of the answer choice is going to be failure of development of one or more digital rays, right? So you're saying this is the deficiency. What was the problem? Possibly what was the gene involved? On this, I don't think it's that obvious. Maybe Hox, but if they're talking about primarily the anterior posterior pattern, I want you to remember that a sonic hedgehog is involved. Now, this is a traumatic event, nothing genetically problem, just by chance you get this banding. If you get some sort of amniotic band that forms, you can get a constriction or inadvertent amputation of whatever's constricted. So that tends to happen. They could ask you that. Piece of cake. All right. Lastly, this Bactrial sense. This is a compilation. I don't know if they know exactly why they all happen together. It has to obviously do with embryogenesis, but this Bactrial stands for these, and these VACTRL. These don't actually seem like they go together, but just try in your brain to kind of put them together because they'll tell you if you have any of these three, it's technically Bactrial syndrome, okay? Because they will tell you there's some sort of vertebral defect, anal atresia, and they also have some sort of VSD or some sort of cardiac problem. And you want to key in on this as the Bactrial syndrome. They just don't seem like they go together because it kind of composes the systemic system. But just try to put this together. This will come up again. But I think that's it. Yeah, that's all I got.
Hey, everybody. Hope y'all are doing well. First things first, yesterday was Lindsay and Keyshore's birthday. So cheers to them. Yeah, so
thanks, Brady.
if I'm mildly hungover, y'all could blame them for that.
Happy birthday.
Thank you.
Yeah.
Mildly.
So anyway, the agenda today, if you did not come last week, we covered all of the gross anatomy head to toe. We did get a little hammered, not hammered. Yeah, it was fun. But what was I saying? I am a lightweight. But yeah, so the review from last week, we did gross anatomy. It is on the page, the YouTube page. So y'all could watch that. Today we'll cover all the cartilage and bone stuff and all the genetic stuff from the last week. It shouldn't last as long as the one last week. So we do understand you guys are stressed out. It is difficult because you just, the bottom line is you can't learn everything, right? So you have to filter out what's important. So the analogy I like to use is that your brain is an iceberg and the facts that you learn are penguins. So by the time the test comes, your iceberg is full of penguins or information. So every new thing you learn, a penguin gets put on the iceberg and another penguin or fact falls off the other side, right?
The high yield penguins.
The point is focus on the high yield penguins, all right? You can't learn everything. Learn the stuff that's important, meaning learn the clinical applications, stuff like that. Nobody's gonna ask you to draw the brachial plexus. So, clinical, stay clinical, keep it clinical. All right.
I feel like we need our penguin gif.
We need our penguin. Yeah, if y'all see the running joke on our pages, that's the joke. Penguins get murdered and stuff because everybody forgets everything. All right. What else? Let's see. All right, just a few things. So if y'all been to the reviews, y'all know this already. On the Scrubs page, if you go to the About section, the Term 1 channel that you guys, all of the videos are unpublished, right? So you can't, if you access the channel, they won't show up. You need to bookmark this. If you bookmark that, it'll bring you to the playlist. All the Term 1 videos are here that we've done since Lindsay and I started this thing. So all your stuff will be there. Just a side note, if you are going down to the island and you haven't seen the Back to the Island Q&A that Lindsay and I did, Kishore was there too. I believe, yeah. If you haven't watched that, you might want to watch that. Got some information on going to the island. We look forward to seeing you guys down there. Lastly, this is not affiliated with school or IEA, but you should join the follow IEA on Instagram. Once the next term starts, we're going to start doing the facts of the day again for each term. Also, all of our tutoring, the honor students all do tutoring. So all the information will be here. It'll be on social media. For those of you fortunate enough to get above a 90, you'll be able to join IEA, the Honor Society, and you'll be able to offer tutoring. There's a lot of good benefits that go along with that. So follow IEA on Instagram and keep an eye out when the next term starts on social media, on your Facebook page, class page, and we'll send out the applications for that. All right, Lindsay, you got anything to add before we get going?
Nope, but if y'all want to go follow the SGA IEA Instagram too, go for it.
Yes, Lindsay is now the School of Medicine president for SGA. All right, so let's get going. And as always, this is very informal. So if you guys have any questions, just stop me and we'll go through it. All right, I'm on Scrubs. You'll find all my information there. Lindsay runs Dog Mom DES. Go check out the additional resources, just a bunch of stuff in a folder, charts, tables, graphs, questions, anything you might find helpful. All right, make sure you're doing the grades questions. The best linear correlate to how well you do on these type of exams is how many questions you do. The boards have shown statistical evidence. The best scores come from the people that do the most questions. That doesn't mean slack off on the other stuff. It just means at some point you have to go from passive learning to active learning, like soon, because obviously the closer you get to the test, the more questions you want to be doing. There is an art to answering these questions. It's not just do you know the information, but how well you can understand the way the question is set up. So do the grades questions, do the Sakai questions for the stuff we're going to do now, and you should be good to go. So let's start out with this. Yeah, go ahead and private message any of us with these answers. All right, so let's take a look. So a couple of buzzwords. Y'all are going to get into this in pathology later on. They're just kind of introducing you to this stuff. Key things here, no scab, meaning you already went through the process of injuring yourself, the inflammatory mediators got there. You formed a scab, the scab healed to a degree, and the scab fell off, right? So we're deep into the process or further along into the process. It's actually the maturation phase. So you can see here, as soon as you get some sort of injury, you get vasoconstriction to stop the blood flow, and then you get some of these mediators, these inflammatory mediators that go there. And then you also, then as the blood stops and you kind of clear the infections or put it at bay, you can, the scab will form over that. And then after, the proliferative phase will be when everything kind of grows back together and holds strong. And then the maturation phase is the phase we're talking about. That's the point at which there's no scab left. And this scar is kind of they refer to it as a hypertrophic scar, right? It just kind of pinches together, right? As everyone's been injured and knows what I'm talking about. It kind of has that pinkish appearance to it, right? So those are the classic hypertrophic scars. Okay, so even though the formation of cartilage and bone seems very similar in their orientation, they are completely separate. Some of the words kind of carry over, and we'll talk about that. But the formation of collagen and cartilage is separate. But in the process of bone formation, you actually form cartilage first, okay? So keep them separate, but they do kind of go hand in hand, if that makes sense. So we'll kind of go through these. Anytime you see these grouping patterns, these what they say isogenous groups, you want to think about cartilage, okay? This is kind of how these cells form. You want to keep in mind the different areas. They could easily put some sort of histology slide on there. So capsular matrix is going to be within one of the cells, one of the collagen cells or the cartilage cells, or one of the little groupings here. The territorial matrix is going to be right around it, right around the little grouping or in between the grouping. And the interterritorial space is going to be between separate isogenous groups, okay? So I seem to remember, even though it seems like we were doing this so long ago, that they did ask sort of questions similar to that. Now, there are 3 different types of cartilage, and being able to identify the differences here is going to be important for the test. Remember that cartilage is type 2 collagen, right? So the way to remember that is cartilage. 2 is type 2 cartilage, okay? So that's what we're talking about here. Hyaline cartilage, you could see, they talk about it as having this glassy appearance to it. So you could see that here. Elastic cartilage, this is a special stain they use. It's very similar to hyaline cartilage, except it has these elastin fibers here. And for a question coming up, I'll give y'all a hint. You don't necessarily need to use this stain here, okay? And I put the question coming up dealing with that for that exact reason. And then fibrocartilage is more of a tougher type of cartilage, like fibrotic, you know, it's not fibrotic, but fibrous tissue. So it lays down in these grouping patterns. You see these linear groups right here. So it lays down flat. So you want to be able to differentiate these histologically and in their different patterns of growth. So hyaline cartilage is the main one we're going to talk about. Whoops. And you could see that here, you see these little isogenous groups and this glassed over sort of appearance here. What I want you to focus on is these different things. The growth, there is appositional and interstitial growth, which we're going to get into. It does not degenerate and it will calcify. Okay, so there are differences between the different types of cartilage. One of the important things is hyaluronic acid is part of this. These gags are commonly considered that they hold a lot of water. So by doing that, they act as an absorptive or a cushioning effect. So keep that in mind. So definitely no growth, degeneration, calcification, because that's going to help you differentiate it on the test. Now, you want to differentiate this from bone, but appositional growth always grows from the perichondrium. All right. Chondrium meeting cartilage. So perichondrium is the outside of the cartilage. You have to have a perichondrium to have appositional growth, okay? That's easy points on the test. If there's no perichondrium, which we'll look at some of the areas that don't have it, you can't have appositional growth. Now, interstitial, kind of, which means inside, grows from the inside, and we'll take a look at that too. Now, there are some differences in bone, and when we get to that, we'll talk about it. So the joints, the articular cartilage, like at the points where joints come together, there is no perichondrium. And that makes sense because if a joint, think about your hip bone, right, into the pelvis, if the femur is in the hip bone like that, you really don't want that articular cartilage growing anymore because it fits tightly in there. So the articular cartilage is type 2 collagen. And it is hyaline cartilage, but it doesn't have a perichondrium. Therefore, you won't get appositional growth there. Important point. Okay. Now we look at elastic cartilage. So some of the difference here, do y'all remember which ones? There was like a way of remembering what is elastic cartilage. It was like pinna, it was like the P's. Do you remember, Kishore? The pinna, what was it? Do y'all know? E's? What?
Epiglottis. Ear.
Epiglottis. What else? There was third one, right? Epiglottis.
Eustachian tube.
Eustachian tube, that's it. Good job. Yeah, right. So if you think about that, right, exactly. So, and if you think about that, those areas aren't going to calcify, okay? So the ear, your ear is not going to get hard. It's not going to calcify, but that does differentiate it from hyaline cartilage. So this is elastic tissue. Recently, they started using, there's different types of elastic tissue with people's names and stuff. So you may want to learn those. I think I have a question of it, about it coming up. But this is a classic elastic stain. You can see these little elastic fibers kind of intermixed in there. Okay, and then fibrocartilage. And you could see if you trace the little cells here, you could see they're kind of laid down in rows, okay? So the growth, there is no perichondrium involved. You're only going to get interstitial growth. So it's only from the inside. Okay, and so definitely make sure you know this. This is, I guess this is a Mallory trichrome stain. Looks like it. All right, try this one. All right, so I put this in here for a reason. It is from Lippincott, so technically it's fair game, but this is actually elastic cartilage. The reason I put it in here is because here it is. The classic image we see is this elastic stain, but I don't want y'all to get tripped up and just think automatically this is hyaline. Ideally, they will use this stain because you can appreciate the elastic fibers better, but identify the isogenous groups. They do have elastic fibers in there. But yeah, so again, make sure you can differentiate these. You don't really see, if you really had to determine it, you really don't see this glassed over appearance, and the cells are kind of more bunched up in this picture. Would be a tough question, but I just wanted to show y'all that. All right, small little differentiations here. Try this question. Cool, right. So remember, what are we talking about with appositional growth? We're talking about perichondrium. Now, here's the thing I want you to keep in mind. Oh, remember, so when we talk about, let's get into the blasts and clasts, right? So chondroblast, chondro meaning cartilage, blast, I want you, when you see the word blast build, okay, BNB, blast build. So chondroblast, these chondroblasts are gonna build cartilage. Clasts are gonna eat it away. Okay, so the chondroblasts are going to lay down cartilage. And when we talk about the bone, the osteoclasts are what we're going to talk about in that regard. But just remember for right now, just remember the blast build, okay? And anytime we're talking about appositional growth, we're talking about the perichondrium. Now, the difference here is that when we talk about interstitial growth, we're not using chondroblasts. We're actually making mature chondrocytes. You're in the inner part of the cartilage, you're laying down fully formed chondrocytes, okay? So that's how you're building. So remember, keep the blast on the outside and you're laying down fully formed chondrocytes in for the interstitial growth. Yeah, so right, interstitial growth. Okay, and this, just showing this again, right? So the appositional versus interstitial, that's how we're going to do it. Y'all don't really need to worry about this too much. Obviously, growth hormone, anytime you talk about thyroxine, thyroxine is basically your thyroid, your T hormones, your thyroid hormones. They're involved in metabolism. Y'all will get into that later. So obviously building bone, testosterone obviously helps to build any sort of glucocorticoid will kind of stunt your growth and stuff like that, even estradiol. Y'all will get into that later. I don't think that's terribly important right now. All right, so let's look at the, now we're gonna switch over to the bone. But even though it's a different process, watch how some of the words carry over. Now, instead of using chondroblast, we're gonna use osteoblast, osteo meaning bone, blast meaning build. But you could see here, the perichondrium is gonna lay on the outside of this bone. And this is a very important point because when you talk about appositional growth, you're talking about width, okay? The bone is getting wider. Okay, and that makes sense because if these osteoblasts are laying here on this periosteum, right? So you need an appositional growth, periosteum now, and then these osteoblasts. By laying down these osteoblasts, they can form osteocytes and the bones get wider. We're also going to talk about endochondrial growth, and that's how the bones get longer, right? And that's from the growth plate, which tends to close around 18, right? And that's when you stop growing, around that age, right? So again, remember, keep the blast on the outside, and then these osteocytes are going to be more towards the fully formed bone. Okay, somebody help me out here. What are we looking at? This is fair game for the test. If we said this is some forming of the bone, what do y'all think one is?
Blast.
Yeah, right? Like, let me go back. You see this right here? Look how it's laying on the outside of the bone, right? So look here, you see the bone forming? Yeah, so we would say this periosteal layer is right around there. So it is making the bone wider, thicker, right? Okay, now what about two? What are these big multinucleated cells? Yeah, osteoclasts, right? Gonna eat the bone away. They are controlled by PTH, parathyroid hormone. And parathyroid's hormone is going to, y'all did cover that, right? PTH, yeah, y'all did vitamin D.
Yes.
Yeah, to a degree. We'll talk about it in a little bit. Yeah, so with PTH, parathyroid hormone is released. You're going to increase your blood calcium, okay? But we'll get there when we get there. All right, so yeah, these multinucleated big cells are the class. They're going to eat away at the bone. It is kind of a last resort. Ideally, your vitamin D levels are good. You'll absorb the calcium. All is well there. If for some reason you have a calcium deficiency or vitamin D deficiency, the last resort is PTH to be elevated. You're eating calcium off the bone, but again, this is a last resort thing. Ideally you would just get it from your diet and modulate it through the kidneys. All right, so just I remember thinking confused. I'm like, why do you want to eat the calcium off the bone? It's like, well, this is a last resort kind of thing if you're at a deficit, a severe deficit. What about three? What are we looking at three? Yeah, osteocytes, right? You could see them in this matrix, the lacunae, right? They're sitting in the matrix. Yeah, so they're the fully formed cells. Cool. All right, just a summary. Y'all could read this on your own if you like. Same thing here. We're going to talk about the canals. Now, just for completeness sake, there is this intramembranous bone formation. This is confined to the flat bones. They use these a lot for bone taps, for bone marrow biopsy, or bone marrow taps, bone marrow biopsies, like in the hip and stuff. So you could do these, but if anytime you're talking about the intramembranous, you're talking about flat bones of the skull, the pelvis, stuff like that. When we talk about the long bones, we're going to be talking about this endochondral bone formation. This is a very important slide. You will get a question on this. They like this at clavicle too as well. Yeah. So you're going to see this picture a lot, right? So we're going to walk through it a little bit coming up, right? So remember that the epiphysis is here, diaphysis is down here. So you're going to start here. Remember I said that the bone formation is going to start out as chondrocytes, all right? So you actually have calcified cartilage, you have reserved cartilage. They talk about this zone of proliferation as a stack of coins appearance. Now, if there's anything you could get confused, it would be the zone of proliferation versus zone of hypertrophy. My advice would be to find both of them, okay? If they're asking for one or the other, just find the proliferation, you're going to get an increased number, and then find the zone of hypertrophy, those cells will get bigger. You have to increase the number before you increase the size, okay? So this stack of coin appearance is going to be formed first. Now, think about it like this. If you have this cartilage here on the end of the bone, as the cartilage forms into actual bone, it's going to lay down on the shaft of the bone, right, on the diaphysis. And this is going to be your growth plate. So we're going to look at, I think I have some more questions coming up. Or some question that y'all can look at here. Now they do this. I forget what the stain is called. Do you remember what this is? This stain. What is this called?
Indian or Indian ink.
Indian ink. Yeah, that's it.
Indian
right?
ink.
Yeah. Okay. So yeah, we'll just look at the cartoon here. The Haversian canal is going to be coming through this osteon, and it's going to bring blood flow through. The perpendicular canal that goes across is Volkmann's canal. Now, they could ask you about the osteon. Those are going to be those concentric layers that form around the vessel. I think about it as like the rings around a tree, right? The older the tree gets, the more rings it gets. It kind of looks like that. And you could see these interstitial lamellae are basically old osteons that are remnants of it, right? When the new osteons come up, they kind of take over the area. And then there's these outer layers, the circumferential lamellae, the inner and outer one. But these are going to be fair game as well. So find the circles, find the osteons. 3 is going to be your Haversian canal. That's going to be the blood flow that comes up. Let's see, Volksman canal. Oh, you can see it here, right? It runs perpendicular to this. You can see that. And then the osteon is going to be this whole circle, like the concentric rings. And I think that's it. What is 4? Yeah, the interstitial lamellae, right? Those are the old osteons that used to be there. And then if we zoom in a little bit, the interstitial lamellae over here, you can see the whole osteon, the Haversian canal is in the middle. 2 is going to be the lacunae. The lacunae is where the fully formed osteocytes live. Okay, so how it works is that 3, where's 3? Oh, you could kind of see it here, but you could see these canaliculi are little pathways for nutrients and whatnot to get to the osteocytes and for communication. So you could see this, but fair game, the osteocytes are in the lacunae, they communicate through the canaliculi, all right? So you got to get blood flow nutrients to keep everything alive. All right, try this one. Yeah, good. So, right. So when we think about that appositional growth on the periosteum, and you think about those osteoblasts laying down there, this differentiation, these osteoblasts are going to form from the mesenchyme to the osteoblast to form these osteocytes for this appositional growth. So anytime you see stimulation of differentiation, you're trying to lay down more bone, right? Versus osteoclast when you're trying to resorb it and get the calcium back into the blood. Yeah, right. And we saw that in the picture. Okay, y'all didn't, well, this is kind of going back too, but this is a good question. Go ahead and try this one. All right, so it may not be directly evident, but this is a good thing to know in the future. Osteoarthritis is going to be classic. You're going to see this, these bony, what do they call them? These, they're bony enlargements, but they're like osteophytes, I believe is what they're called. And these nodules form at the DIP joints. It's very classic for osteoarthritis, okay? So just keep that in mind going forward. Why is this common? Why is osteoarthritis common in postmenopausal women? Low estrogen, exactly. Estrogen has the effect of inhibiting osteoclasts, all right? So for premenopausal women, the estrogen will block the osteoclasts so you don't resorb bone. For postmenopausal women, the osteoclasts can work without inhibition because there's not a lot of estrogen around, okay? So they're gonna eat away. That's why elderly women tend to get osteoarthritis. Okay, keep that in mind. It's actually through the osteoblast. There's the osteoblast inhibiting factor. It may be out of the scope of this curriculum, but just in case they ask, but it does inhibit the osteoclasts. Yeah. And you could see that, well, yeah, go ahead and answer the question. And this is why a lot of times that postmenopausal women will actually stay on birth control or get some sort of exogenous estrogen to prevent not only the symptoms of menopause, but the degeneration of the bone. All right, so postmenopausal women will have increased osteoclast activity. Again, that is because of the decrease in estrogen, right? Okay, so let's look at this. I would bet, whoops, I would bet that this would be on your exam. So make sure you could identify these. Yeah, right. So be careful because we're talking about area 3. Now, what is area 2? That is going to be your zone of proliferation. That's where you're going to get this stack of coins. So this is the reserve cartilage over here. You're going to get the proliferation, right? Increased cells, a stack of coin. And here you can appreciate it's kind of difficult, but you can see that some of these cells are getting larger. So that's the zone of hypertrophy. Okay. So, and yeah, you could see zone 2 proliferation, that's our stack of coins. So the idea here is if you find both, you could kind of differentiate them. But if you were to mix these up, mix this question up, that would be where it is between hypertrophy and proliferation. So yeah, find the stack of coins. When they get bigger, that's hypertrophy. Remember, you're starting at the end of the bone and with cartilage. And once you get to the shaft, that's when you're laying down mature bone. Cool, try this one. Yeah, primarily area 2, the zone of proliferation is going to be the larger of the zones. So your growth spurts would be pretty much in that area. Right. So like I was saying, that proliferation zone is going to be where most of the growth goes. So if we go back and look at it, you could see that it's the larger of the zones. You're increasing the number of cells. So that would kind of make sense, right? And that's where obviously if you're increasing the number of cells, there's mitotic division going on. All right, and then once again, we're looking at it going from up top to down low. You could see reserve cartilage, proliferation to hypertrophy. It's easier to see here that these cells are getting larger, but it may not be so obvious on the exam. But I've gone through this a couple times, so definitely know it, right? All right, try this one. Yeah, this one's a little tough, right? So it's basically asking if you can define what the soft callus is, right? So the soft callus is going to be cartilage and dense connective tissue. That's what we're going to be forming here. So you could see initially when you have a fracture, you want to form a blood clot, right? You want to stop the bleeding, and then you could form a soft callus, right? And then from a soft callus, I think there's another slide, you could form a harder callus with spongy bone. And then once the spongy bone is remodeled, you get compact bone, right? So spongy is going to have like a sponge, going to have holes in it, and it's going to form fully compact bone, right? So this is the area that we're talking about. This soft callus, dense connective tissue is what you're thinking of, and obviously fibrocartilage is involved. All right, again, y'all will do this a lot more in pathology. I just wanted to mention it to you guys. And then once we actually have this fully replacement of the bone, it's going to be endochondral, right, from the inside, growing outward. All right. You need to know vitamin D inside and out just forever. So go with this one. Yeah, they really like this vitamin D pathway. So this is actually common. This is a pertinent clinical correlate, right? So the point being, chronic renal failure in the kidneys is where you actually have this one hydroxylase. One hydroxylase will convert 25 vitamin D to 125 vitamin D. 125 vitamin D is the active form. So if we look at the pathway, this is the metabolism pathway, as I said, 25. It is turned into 25 in the liver from cholecalciferol to 25. By 25 hydroxylase, technically, if you have liver failure, you can have issues there, but they really like testing on the kidney failure, the renal failure, just because it's that conversion from 25 to the active form, right? So if you can't form the active form, the enzyme you need, it's a problem. And the enzyme you need to know, one hydroxylase there. So let's see. All right, so we'll go through the process. Vitamin D and PTH work together, right? The whole goal is to keep your calcium levels up. Now, there are a few little differences. Vitamin D is primarily going to work in the intestines, in the gut. The vitamin D is going to be it's going to be transcribed. It works similarly to a steroid hormone. It goes into the nucleus. It is going to basically pull all of the excess calcium from the lumen, from the meal you eat, and bring it back in. It's also going to absorb phosphate too. So calcium and phosphate in regards to vitamin D are going to go together. Okay. Now, in regards to PTH will primarily work. Ideally, it'll work in the kidney. Now, the difference here is that it will tell you to reabsorb calcium, but it'll also tell you to get rid of or urinate out the phosphate. You don't want calcium and phosphate technically together a lot in the kidneys because you could form kidney stones, right? So big difference y'all need to know right now, and y'all will get into much more detail later. But the big difference is that vitamin D is going to absorb calcium and phosphate from the gut primarily. PTH in the kidney is going to keep calcium, get rid of the phosphate. Okay, so when you talk about some of these disorders that they have, you could see elevations or differentials there with hyperparathyroidism and stuff. So keep that in mind. And like I said earlier, ideally the PTH doesn't want to act on the bone, right? It will if it has to, but ideally you could handle it in your gut. But if there's, for some reason, there's a big deficit, it can go eat up on the bone and because obviously you need to have your calcium levels adequate in the blood. So if it has to pull it from the bone, it will, but that's not an ideal circumstance. All right, good. Right, and you can get like tertiary hyperparathyroidism with vitamin D deficiency. Vitamin D deficiency, then you get decreased calcium, and then you get increased parathyroid hormone. So it's another thing when y'all get to endocrine next term. Y'all will talk about that in much more detail. All right, genetics, and some of these genetics diseases come back again and again because they like to be tested. Whether we'll see them clinically, it's not exactly important. It seems like every other person has Marfan syndrome, but you may never come across it in clinical practice, but it's just a good way of testing some of these genetic principles. So go ahead and try this one. Get out of here. I don't know, have y'all covered pheochromocytoma? Have y'all? It's a running joke.
Yes.
Like everybody that has like elevated heart rate has pheochromocytoma. It's like, It's like it's fairly rare, right? Like it's so, but yeah. All right, what are we doing? Okay. Fibroblast growth factor, you need to know these genes. Again, one of those things, the sooner you learn them, the better off you'd be. So what are we talking about? It's trident hands, and I like this question because it's not exactly intuitive when you talk about it. So what disease are we talking about here? Growth factor.
Achondroplasia.
Achondroplasia, right? I try to remember growth, fibroblast growth factor. Talking about achondroplasia. Now, I think we talked about previously, there are 2 gain of function mutations that you need to be aware of. Huntington's disease, you gain the function of this this flailing movement. Y'all know about Huntington's with the anticipation, right? Those trinucleotide repeats. So, and the other one, the other gain of function mutation you need to understand is achondroplasia. And you may say, well, what is the gain of function? Technically, the gain of function is the gain of the ability to close the plates. It's not a good thing, but it technically is classified as a gain of function. Now, by closing those growth plates, by closing the epiphyseal plates, obviously that'll stunt the growth. Now, let's do this. Well, not exactly, but if you didn't necessarily know trident hands, you want to use the test to your advantage. This is one of those art of taking these sorts of tests. Sometimes it's easier to rule out 4 answers than it is to rule in the correct answer. People that write tests are good at writing tests. The doctors that write the board exams, that's their sole job, right? So they know what they're doing, but the more questions you do, the better off you'll be. So pigeon chest is classified as Marfan syndrome. Brittle bones, you know, OI deals with brittle bones. Cardiac abnormalities is kind of vague. It's very common in Down syndromes. You get VSDs. We'll talk about that when we get to cardio. DeGeorge, y'all know catch 22. The C in catch is for cardiac abnormalities. And then MR is many causes. So point being, you need to know these genes. You could kind of get it from the other stuff, but if you know the genes, you definitely know it. All right, we kind of just talked about this. Huntington's disease, achondroplasia, you need to know those as gain of function mutations. All right, try this one. Pigeon chest can be rickets as well, yeah. But that's more of, rickets is more of a nutritional deficiency. So you wouldn't, you know, when we're talking about these genetic deficiencies, you know, it does happen in Marfan's too, but it has to do with, you know, the fibrillin gene, the cartilage lacks cartilage. But yeah, you could see pigeon chest and rickets, and they also have the bow leg, yeah. All right, so this is actually fairly common. What they'll say is a child comes into the ER and for a fracture, and when you do the x-ray, it looks like there are multiple fractures that are healing at different times. So you call child services, right? You're like, what's going on? Why are there so many fractures at different times? But in regards to these questions, a lot of times this has to do with osteogenesis imperfecta. Now, again, if you knew this gene, you would get it right away. But even if you did it, you could kind of get it from the questions, right? So some of the differences, blue sclera is just a straight giveaway. You know, that's osteogenesis imperfecta. Sometimes they get hearing loss. They do get short stature. But that's the main ones. That blue sclera is definitely a giveaway. And you're looking at fractures that are healing at different times. Okay, as for these, y'all will get into the yellow sclera later. Has to do with bilirubin. A lot of liver problems, liver diseases can cause that. Again, in regards to genetic deficiencies, pigeon chest is Marfan's, and ruptured aorta is Marfan's too. This is why people with Marfan's are not allowed to play sports. I don't know, I probably told y'all this already because I think this is a crazy story. There's a guy that he was like 20, played for Baylor. He was getting drafted into the NBA, and he had historically in his past, he had subluxation of the limbs. You guys, we all could look at him and be like, that dude's got Marfan's. Like his fingers were long. He's 7 feet tall. Throughout his entire youth career, nobody diagnosed him with Marfan's. He gets to the league, he's about to make millions of dollars, and they said, you have Marfan's, so we're not going to draft you. And so he lost millions of dollars. But the point of the story is that the clinical complication of Marfan's is this ruptured aorta. You get a tearing of the media in the aorta, the middle layer, and it could lead to sudden death. Okay. All right, try this one. He's playing in a different league. I did not know that. That's wild. Huh. All right, so this is a little bit more complex. We're kind of diving into the different variations of osteogenesis imperfecta. Now, the point mutation is going to be a dominant negative mutation. So we'll stop and we'll talk about the differences between dominant. So basically, you were going to go between, it's between A and B, right? One's haploinsufficiency, one's dominant negative. So dominant negative means that you have some normal protein, for instance, and some abnormal protein. So the dominant negative one is going to counteract the positive one. So in regards to the bone formation, they're going to be very brittle because you have some normal, but a lot of abnormal, right? So it's going to be very brittle. Haploinsufficiency just means you have a decrease, whereas you're supposed to make 100% of this protein, you make 75% of that protein. It's all normal protein that you're making, you just have decreased amounts of it. So it's an insufficient amount. Whereas dominant negative is you're making normal and you're making abnormal, and this negative effect of it is going to counteract the positive. So it's important to know that, because in regards to the different ones, different correlates. So a nonsense, remember sense means it's going to cut the DNA strand. It's going to have an insert a stop codon there. So that's going to be OI type 1, whereas missense is going to be switch that amino acid around. And that's type 2, and that's a dominant negative. Fair game, they could ask you this. So this is from your notes or from our old notes, whereas type 1 OI is going to show the blue sclera, type 2 is very severe. And so when we think about this in regards, remember OI is a structural protein problem. So why is type 2 worse than type 1? Well, this dominant, in regards to a structural protein, this dominant negative effect is worse than a haploinsufficiency, meaning it's better to have less of a proper protein, right? Haploinsufficiency, than have half normal protein and half abnormal, okay? So even though an insufficient amount, at least it's all normal, right? It's still going to be brittle, but it's not that bad. It's not as bad as having these completely messed up, this messed up portion of them. So that's in regards to that. But keep those separate. And you can kind of see that here. Let's see, this missense mutation is putting in these abnormal proteins. So this is what this slide was kind of getting at here, the severe thing. So the idea is that you're getting 100% of a protein, but half of them are messed up. So the bone's just going to fracture. Whereas with the haploinsufficiency, opposed to getting 100%, you're getting 80%, but at least all 80% is normal. You just have a decreased amount of it. You can see that, this haploinsufficiency. So you get normal, they're just less of it. All right, and it comes to this, and so this is why I'm harping on this. You can't just definitively say that, well, in that case, haploinsufficiency is always going to be better than a dominant negative mutation. It is in regards to structural proteins, okay? But when we're talking about enzymes, it is worse to have haploinsufficiency, because you're going to get this nonsense in regards to nonsense mutations. Because in regards to the enzyme problems, if you get a nonsense mutation, you're going to mess up the enzymatic process, right? So it's going to be completely messed up. Okay, so this is getting a little more complicated, but this was in the notes, so I just wanted to make sure to go through it. So just read through these and understand that the bottom line is that you can't definitively say haploinsufficiency is better or worse than dominant negative. It just depends on what we're looking at. Is it an enzyme problem or is it a structural protein problem? Because that'll kind of tell you which one's the worst situation. All right, try this one. And what is this? What are the two and which one is this? Does it say in the question? No. Becker's is in frame, this is DMD, right? So if you're thinking about it, frame shift mutations are really bad, right? It changes because you're bumping the amino acid or the codon down one, right? One base pair. So that means that all of the amino acids, the triples, the three codons are going to be different all the way down. So a frame shift mutation is going to be worse than an in-frame mutation, right? An in-frame mutation would just change that one amino acid, like a missense mutation, whereas a frame shift is going to change all the amino acids all the way down. Therefore, Duchenne's, which is frame shift, is much worse than Becker's, which is in frame. Okay. And they say, some books say complete absence, some books say almost complete absence. There's basically no dystrophin there, okay, the dystrophin protein, because of this frame shift mutation. And sadly, these children typically are wheelchair bound by 20. They die by, I'm sorry, wheelchair bound by 12. They usually die by 20. So this is commonly, this is not they have a zero reproductive fitness. The assistant passed along. This is a de novo mutation that happens in these kids. Whereas Becker's is in frame. Some of them do get to reproductive age, but so you have decreased amounts of dystrophin, whereas Duchenne's is a complete absence. So you can see that here, if they stained this, they did a muscle biopsy here and stained it, you can see this bottom is Duchenne's. You don't see any of that dystrophin. Becker's, you see a little bit, and this is normal. So again, frame shift, in frame, normal. All right, if it was like us, this was like a 70-page DLA or something. I don't know if y'all had that too, but I'm sure y'all cover the same material regardless. But we'll talk about some of the diseases that were covered in that. All right, cool. So let's walk through this one. Okay, so these the liver enzymes are in charge of metabolizing drugs, right? They are called CYP450s. That's kind of the umbrella name for all of them. But some of the, so they'll be like CYP3A4 or whatever, but the one we're talking about here in this sense is the specific CYP450 called CYP2D6. Now, what you need to know is some medications, the majority of medications that you take are active when you take them, and then when they hit the liver, they are inactivated. But some medications that you take are inactive, and then the liver is going to metabolize them into the active form. So this guy was given codeine. Codeine is the inactive form of morphine. Let me just draw this out for you guys. So this is codeine. Codeine is changed to morphine, okay? Morphine is the active form, codeine is not. So the idea here is that he metabolized codeine too quickly, right? Now, by metabolizing, like when the pharmaceutical companies have a general understanding of this is how much is going to be metabolized the first time through the bloodstream, through the liver, through the second time. So if you are an ultra rapid metabolizer and you take the inactive form and are metabolizing it to the active form, you're going to metabolize it too quickly, meaning you have too much of the active form in your blood. What are the side effects of morphine, right? The side effects of morphine overdose is respiratory depression. Where does it say that? Difficulty breathing, okay? So this is an example of you taking something inactive. The liver, this CYP2D6 is gonna activate it, or sorry, is gonna metabolize it to the active form, okay? Morphine, right? So that's used for analgesia, for pain, so if you're an ultra rapid metabolizer. Now, the other example that they give you is metoprolol, okay? Metoprolol is a beta blocker. It's used for blood pressure, for stage fright or stage anxiety. It helps to regulate your heart rate, whatever. Y'all don't need to get into that. Actually, y'all did cover that, I think. Anyway, it's blood pressure medication, but we want to use it here in this regard. So let's just use X as an example. Metoprolol is active when you ingest it, okay? So let's say you are a poor metabolizer in this case. The pharmaceutical company is going to assume you being a normal metabolizer, you're going to metabolize a certain amount of this metoprolol in a certain period of time. But if you're a poor metabolizer, that means you're going to have too much of the active form. You're not going to metabolize it to the inactive form quick enough, okay? So you can get symptoms of feeling faint or hypotension or orthostatic hypotension, where when you stand up, you feel lightheaded and stuff. Even bradycardia, your heart rate will go down. So you can see the difference here, right? So you need to remember codeine is inactive, changes to morphine. You can see problems with that with ultra rapid metabolizers. And metoprolol, which is already active, is inactivated. So if you're a poor metabolizer, you'll have too much metoprolol. All the drugs go through this process. These are just two examples that they want you to know. What you'll come to find is that there are even medications that will affect these CYP450 enzymes, stuff such as grapefruit juice. People drink alcohol with grapefruit juice because the alcohol stays in your system longer. That's because grapefruit juice will inhibit these CYP450 enzymes. So you'll see that certain medications or certain diseases, you can't take other medications because they will slow down or speed up these. So this is going to be a common thing. You need to understand the differences there. All right, so there's explanations here for you guys. Talk about these. TMPT polymorphism. Okay, so they give, so for diseases like bloodborne cancer, such as leukemia, they can give certain medications, these thiopurine drugs. They help to decrease the amount of purine synthesis. Y'all kind of touched on that in FDM. So if you have this TMPT polymorphism, you're going to get too much of this drug in your system, and it's going to oversuppress, lethally oversuppress the leukemia. So the idea of these thiopurine drugs is you're going to decrease the amount of extra blood that you're making. But if you have this polymorphism, it's too strong, okay? So that's all you really need to remember. Keep this TMPT polymorphism in line with myelosuppression, like too much myelosuppression, okay? This ranitidine receptor is an important thing too. So what are the two drugs? Succinylcholine and what's the other one? Halothane, that's it, thank you. Succinylcholine and halothane, they use those for anesthesia. If you have this ranitidine receptor mutation, what ends up happening is when you take halothane or succinylcholine, this ranitidine receptor, there's an influx of calcium that's uncontrolled. So you end up getting these, you end up getting tetany, right? Because the calcium, you'll lock up, and you also get malignant hyperthermia, and that's because of the muscles locking up. So this is a big deal. It's very rare, but it's something they test on. So this ranitidine receptor allows calcium to flow in. So if you have a mutation there, you'll have too much calcium. The patient, will be going under for whatever sort of procedure. You'll give them typically succinylcholine. It's a non-depolarizing. You'll get into that later. Blocker, but so you'll give them that, and all of a sudden, their muscles will lock up, their temperature will go up, and that's a huge problem, right? So keep those. Yes, that reaction is specific to halothane and succinylcholine. Yeah, they'll put that in the stem so you know what they're talking about for sure. Fragile X, that's one of those trinucleotide repeats, along with Huntington's, myotonic dystrophy, and Huntington's, and there was another one too. I can't remember off the top of my head, but yeah, those. Okay, and then this is what we were talking about, these poor metabolizers. So you can go through this on your own. If you're still confused, I'll stay back. Yeah, ataxia, that one. Friedreich's ataxia was the other one, thank you. And we could go through this again if you're still confused, because it is a good point to be made. All right, try this one. More importantly than getting the answer, you could tell me what disease we're talking about. Yeah. Yeah, so this sudden, jerky, purposeless movements, it's bilateral, which is important. So you're going to get this is Huntington's disease. This is called choreiform movements. This jerky, purposeless movements. They're uncontrollable. Yeah, so this is Huntington's. You would expect this anticipation, right? So if the father got the disease at 50, or the onset of the disease, his child, the guy in question here, will have more of that CAG repeats, right? Meaning you can anticipate that he will get the disease sooner. It's a very rare situation where you have a genetic problem that you're born with that you don't actually get until adulthood. I mean, besides some cancers we talk about, but the idea that, I mean, you could think about the idea that, your father got it at 50, this very severe disease, and you're likely gonna get it before then. But what you'll find out when you get to neuro, the caudate nucleus is what degenerates, and I think there's a picture of it. Yeah, the caudate nucleus kind of sits like right up in here. Right, so over time, this ventral gets larger and this caudate nucleus degenerates. I don't think it's as important to understand this, to necessarily be able to point this out on some sort of CT, but just knowing that Huntington's disease, the anticipation process, and these choreiform movements that form. This is super important. Star this slide. These are the 4 trinucleotide repeats. I think you should know everything on this slide. Like, you need to know that Fragile X is before the start codon, right? It's in that 5' untranslated region. That's a good question. Huntington's disease and spinocerebellar ataxia. I don't think they'll ask you about spinocerebellar ataxia, but it does. They both have that CAG repeat. Spinocerebellar ataxia is more of like a problem with balance than it is this jerky, purposeless movement. But yeah, you do get this ataxic gait, trouble walking, but I doubt they would ask you about that one. If they talk about it, they would talk about one of these 4. So knowing that 5' untranslated, right? 5' is where we start. AUG is our start codon. Fragile X is before that. And just knowing these, what actually is the problem that forms from these actual repeats is going to be important. Friedreich's ataxia is in the region. Definitely knowing the different patterns, X-linked versus autosomal recessive. And what else was there? Oh yeah, it's in the intron, not the exon, because Huntington's is in the exon. The point of this is like there are all very little differences between these, and they all could be asked about. Okay, gain of function. Remember Huntington's, we talked about that, and then myotonic dystrophy is going to be on the 3' untranslated region. Okay, so definitely know these. Oh yeah, I thought we were done. I guess not. All right, let's do these. Muscle physiology. Great. Yeah, y'all are getting this. So the idea of myasthenia gravis is that they have autoantibodies that attach to these postganglionic receptors, right? So it's a little tricky because your first instinct is saying, well, it has to do with acetylcholine. But in order to have acetylcholine release from here, you have to have sodium, okay? So sodium is the answer, but that's definitely a tricky question. Y'all did good with that one. But remember, this versus Lambert-Eaton syndrome, people with myasthenia gravis, if you ask them to repeatedly move, they get weaker over time. This is why they complain of weakness at the end of the day. They have ptosis, which means their lid gets droopy throughout the day. The difference is with Lambert-Eaton syndrome, y'all did talk about that, right? Lambert-Eaton syndrome? No?
Yes.
Yes. Okay. It's all a blur. I don't know when we learned anything. It's just bad. So I just want to make sure. Lambert-Eaton syndrome means that you actually have autoantibodies, same principle, autoantibodies against the presynaptic calcium channels, right? But with these people, it's exactly opposite of myasthenia gravis. When you ask them to repeatedly move, they get stronger with repetition. And the idea is that every time they repeatedly move, they get increased calcium in transfer, okay? And when you more increased calcium means the easier it is for you to move your muscle. So I like to think of them as almost polar opposites, right? And the reason an acetylcholinesterase, I did this in FDM, inhibitor would work is because if acetylcholinesterase blocks the breakdown of acetylcholine, if you block that enzyme, you'll have more acetylcholine in the cleft, right? Yes, Lambert-Eaton syndrome is for calcium channels, yes. Whereas this is acetylcholine, right? Right, well, it would be, right, so this one would be sodium, but Lambert-Eaton, I guess I was getting ahead of myself, is gonna be calcium channels for sure, yeah. Yeah, and you can see that here, these nicotinic receptors. I don't want to confuse anybody, so I'll just say that again. These are going to be acetylcholine receptors. The sodium's going to control that, and it's going to be postganglionic, whereas Lambert-Eaton syndrome is preganglionic, and those are calcium channels. So with myasthenia gravis, they get weakness with repetition. With Lambert-Eaton syndrome, they get stronger with repetition because there's more calcium available for muscle contraction. All right. Try this one. I'm not sure if Lambert-Eaton is primarily in the lower extremities. I'm not sure. Is that true? I don't know.
Don't worry, guys. With the Lambert-Eaton, and they really focus in on myasthenia gravis, but they're not going to test you guys likely on Lambert-Eaton because that you're going to cover it way more in term 2. It's not as high.
All right, good. So these are going to be presynaptic calcium concentrations, and y'all are right. This is Black Widow, or the Black Widow spider, I think it's called, the black spider. Don't laugh, Lindsay. Lindsay likes, that's her favorite Marvel character. It's the Black Widow, that chick. Yeah, latrodotoxin, that's what we're talking about here. This is venom of the Black Widow spider. Yeah, so these voltage gated calcium channels. And keep in mind, because we did talk about this, you get very much similar results, right? Whether it's Lambert-Eaton syndrome and presynaptic antibodies, or you have this toxin, this latrotoxin. Same principle, you can't get calcium. If you can't move calcium across to the muscle, you're not going to be able to contract it. Cool. Oops. All right.
So I have a question. I don't know if you guys saw that question in the chat that Maria asked, but because these genetics concepts are ones that we've already learned, if they ask about them, do you think those count as like the cumulative portion of it, or is that considered this time just because we're learning it right now as well?
It's tough to say, but a lot of times they do that. Like they like to carry things over that are like, they'll carry over a concept that was covered before, and if it was covered again now, like they can count it towards that. Yeah, it's hard to say, but yeah, that does tend to be the case. Like, yeah, common themes carry out through, especially genetics.
Okay,
All
thank
right.
you.
Yeah, no worries. Okay, so yeah, so a lot is made out of this. It's not as complicated as people make. If you were lifting weights, if you're doing bicep curls and you had a lighter load, like a lighter weight, you would contract it faster, right? Versus a heavier load over here. So the shortest length is going to be curve 1. This is the lighter load. If you're lifting higher weights or heavier weights, your shortening velocity is going to go down, right? It's going to take more effort to pull it up. It's the whole concept here, the load that is on the muscle versus the shortening velocity. So don't get too mixed up on that. That's all they're really getting at. And then these are just some basic definitions. Preload is going to, and we're going to talk about this much more detail when we get to cardio. Preload is the load at which it is the initial weight that you're holding in your hand before you actually contract, okay? But they're just introducing you to these concepts here. Yeah, but yeah, this won't be so bad on the test. It'll be pretty straightforward. All right, try this one. All right. Yeah, so the A band, and yeah, that is, if I'm hoping to have a graph. Yeah, A band is going to be the length of the thick fiber, right? So it doesn't change. The only thing that's changing is the thin fibers that come over the thick fibers, right? Now, the H band's going to change, right? Because as these thin fibers come closer, this H band's going to get smaller. So, and then the M line is going to be towards the middle. And let's see, yeah, so I band is going to get smaller. The I band is basically the part that's only thin filaments, but I like to define it as the end of a thick filament to the end of the other thick filament. Either way, it's the same thing, but as this green overlaps over the pinkish area, this I band's going to get smaller, A band's going to stay the same. Just draw this out once or twice as it's relaxed and as it's contracted, and you could work these out. The Z lines are over here. They kind of hold it together. H band's in the middle. H line or band. Band is in the middle. What's the line? M line. Yeah, it's been a while, guys. But yeah, that's in the middle. For some reason, I remember them asking about these silly little proteins on the side too. Titan, there was another one. I forget. But know those. There was like a chart of those that, but no Titan.
Anything that can cause
Nebulin,
the pathology,
alpha
like the
actin.
dystrophin.
Yeah, all those. Know those. Yeah, for sure. I think it was specifically Titan they asked, but yeah, know those. All right, let's see. Try this one. All right, so straightforward. Remember, smooth muscle is very different from striated muscle. Striated muscle is your skeletal muscle and cardiac muscle. Smooth muscle needs to be able to be tonically contracted, right? It like your gut, right? It needs to be tonically contracted at times without getting tired. So it's basically like this clipping system, right? You have to, whereas the skeletal muscle kind of, the tropomyosin and the complex kind of comes and goes, right? This needs to be able to be tonically contracted, and then it needs to be tonically released. So it's like an action to contract it and an action to release. So it uses this calmodulin system, right? So the idea is this myosin light chain kinase is phosphorylated, and you get this tonic contraction. And then you can dephosphorylate it and then get relaxation. Yeah. So definitely keep that in mind. I thought I had a chart. There might be a chart in your book or in your notes that has like skeletal, cardiac, and smooth muscle, and just the differences, the different proteins, the different enzymes. Definitely know the differences there. I don't know that they would give y'all any sort of histology with that. I know the trick, if you're looking at striated muscle, the cardiac muscle has branch points, whereas skeletal muscle is straight across. So I can't remember when y'all did that, if y'all did that for this test or not, but that's a good way of doing it. All right. All right. So the point being, let's talk about it in reverse, right? So this action, well, in regard to skeletal muscle, this action potential, they can almost overlap in regards that it could be tonically contracted. What happens if your heart is tonically contracted, right? It's not pumping, is it? So you have to have a period, a refractory or an absolute refractory period between the beats, and that's built in to the cardiac pacemaker cells. Y'all, we'll get into that much more. We'll get into that next review for cardio, which will be much more fun than this nonsense. Right, so you can actually lock up or tetanize this skeletal muscle. And but obviously your cardiac muscle, you need to have breaks in between. You need to be able to pump, fill up the chambers, relax, right? Pump back and forward. Don't judge me, Lindsay. I see you. All right, and I threw this in here, I think, inside joke. All right, yeah, you need to know these. Remember the power stroke versus, it's always tricky, I always get this backwards, but the point at which the myosin head releases is the point when ATP binds, right? So it releases, and then, yeah, and then you get, where's the power stroke? This is the power stroke, where the ADP, I might be saying this wrong. Oh, Lord. How does this work, Kishore? ATP binds and it releases, right? Am I wrong about
Right.
that?
ATP binds,
Okay,
and
yeah.
then it creates ADP and one inorganic phosphate, right?
Right here.
And in that process, you eject it. So rigor mortis is when you don't have ATP and the muscles are just locked up, and that's it. They can't continue to move along this kind of cross-bridging structure, and it ultimately ends up it's somewhat similar to kind of tetany, but like for this one, when we were asked questions about it, it was very specific to at what stage, where does ATP bind, and how it would look for like rigor mortis.
Right. Okay. So yeah, I said that right. So the ATP, when it binds, it's going to release off of the muscle, right? This myosin that's going to release, and then you get this then this hydrolysis, and then it comes back when it binds as ADP, and then you get the power stroke. So just basically keep in mind that ATP releases it. As Kishore was saying, obviously rigor mortis, after you decease, you don't have ATP, so they get locked up because ATP is not there to bind. One day, very soon, you won't have to worry about any of this anymore. It'll be all clinical medicine, and your patients won't ask about ATP binding or this power stroke or anything. This was that table I was talking about. Just knowing the differences in the enzymes, how it breaks down, stuff like that will be good to know. All right, and Kishore gave it away, but rigor mortis in skeletal muscle, decrease in ATP, right? No energy being made. This was from some silly DLA they gave y'all. Just remember that creatine, for those that work out and use creatine, it is an energy form. It is actually has more energy per molecule than ATP. So it can be used. That's why bodybuilders tend to use it. It is broken down into creatinine in the kidneys, which is a measurement of renal function. But just keep in mind that there are some higher energy compounds, particularly phosphorylcreatine, that can be used for the muscles. And that's all for me.